Hello everyone. Hope I'm audible and visible. So let's start today's class. So today's class is all about Daskadam. That is, in magic of 10, we are going to revise orthopedic very quickly, not taking much of your time. Okay. So let's get started. So what I've done is I have come with 10 important tables, which are very, very important for your PG exam, right? So let's start with the tables first, and then we are going to understand few important images which have appeared in the previous year's exams, and now they might, they might repeat the same topic, or they may repeat the same image maybe. And then we will end the class with one liners. Those also would be 10 one liners. Okay, and then in between we are going to read some of the important topics. Okay, so first let us start with the table 1. Now these are the names of the fractures completely from the upper limb, right? Upper limb fracture eponyms, like that is the name of the fractures which are very, very important. Let's start with the first one. So here it is the Holstein-Lewis fracture. So Holstein-Lewis fracture is fracture of, yes, fracture of humerus shaft, right? It is fracture of humerus shaft whenever there is association of radial nerve palsy. This you have to remember. Whenever there is an association of radial nerve palsy, and this humerus shaft fracture occurs mainly in the distal, that is middle junction of middle and the distal third, right? At that particular area, the radial nerve takes a turn to which pierces the lateral intermuscular septum and will try to come onto the lateral side. So as it is coming from the center, that is from the radial groove to the lateral aspect, here it doesn't, it gets tethered, it gets tethered to the particular bone, and whenever there is a fracture, this radial nerve gets crushed between the fracture fragments. And now that will result in the radial nerve palsy. And how does the patient present with? Now the patient presents with the wrist drop. He presents with the wrist drop, right? So whenever there is a wrist drop with the humerus shaft fracture, then that particular fracture is called as the Holstein-Lewis fracture, right? So very, very important. It is usually asked in the exam. And how this can be asked, if even the question is not asked, the name, if the fracture name was not asked or the palsy was not asked, they will ask you what is the splint used in this radial nerve palsy. So what is the splint which is used here? It is the 𝐒𝐿 splint. So the splint which is used is the 𝐒𝐿 splint. Please remember there are two types of 𝐒𝐿 splint. One is the dynamic 𝐒𝐿 splint and static 𝐒𝐿 splint. How will you differentiate? Whenever they ask you about the dynamic 𝐒𝐿 splint, what you have to remember is there will be springs which are attached here. Dynamic means it is the movement, right? So whenever you see springs attached to the splint, and when the patient can move his fingers with the help of those springs, then it is called as the dynamic 𝐒𝐿 splint. And if just there is a resting of this hand in the functional position, so here what happens, the wrist drop is there is a fail or loss of extension. Right now what we'll do, we'll put the hand in the neutral position, and that is with the help of the splint. Now if this hand is simply placed in this position, no, without any springs, then that is called as the static 𝐒𝐿 splint. When you see the springs which will aid in the action of the extension and the flexion of the fingers, it is called as the dynamic 𝐒𝐿 splint, right? So dynamic 𝐒𝐿 splint. Yes, very good, Sakshi. Dynamic will have springs. This is very important because they will keep asking you about the splints, right? And now, then what is Montegia? What is Montegia? Montegia is, yes, Pratyusha, you're also right. It is a fracture of humerus with the radial nerve injury. Very good. Now, what is Montegia? Now, here you have to remember this Montegia and Galeazzi. These two are the forearm fractures, right? These two are the forearm fractures. But what is so important about this Montegia and Galeazzi that they keep asking? Right? What is that importance is these are just not fractures, but these are associated with the dislocations. So what you have to remember here is the Montegia and the Galeazzi. These two are the forearm fractures with the dislocations. Forearm fractures with the dislocations, right? Yeah. Sakshi, you mean the Montegia is ulnar fracture? Yes, then you're right. So what you have to remember is the forearm fracture with dislocations. Yeah, as Sakshi told, Montegia is ulnar fracture, but that doesn't end the answer. It is ulnar fracture with what? That you have to answer. So it is the ulnar fracture with radial head dislocation. So that radial head dislocation is nothing but which disrupts your proximal radio-ulnar joint, that is PRUJ, right? So that is Montegia. Then what is Galeazzi? Galeazzi is exactly opposite to it. Galeazzi is nothing but your radial, yes, it is the radius fracture. It is the radius fracture with DRUJ, that is distal radio-ulnar joint. Yes, very good. Yeah, proximal, Pratyusha and Sakshi, both of you are right. So what is more important is, please remember that M is on the medial side. That is, medial side is ulna whenever it is with the radial head dislocation. And you also have to remember that these are the image based questions. So usually they will ask in the IBQ form. So they will put up the X-ray of the elbow and they will show you the fracture of the ulna. Right, then you have to always check for one joint above and one joint below. That is the importance of this. So you have to check for one joint above and one joint below. So whenever you see a fracture of ulna or a fracture of radius isolated, you have to always check for the joints above and below. That is the proximal radio-ulnar joint and the distal radio-ulnar joints, right? So I hope everybody is familiar with this. Yes, now let's go to 𝐒𝐿I's fracture. So once we have finished the forearm fractures, now we are entering into the wrist fractures. So these are all the wrist fractures. So wrist fractures, what is a 𝐒𝐿I's fracture? A 𝐒𝐿I's fracture is, yes, what is the difference between the 𝐒𝐿I's, Smiths and Barton's? So let us understand the difference. The 𝐒𝐿I's and Smith, these two are the extra-articular fractures. These are the extra-articular fractures. Yes, and what is the difference between 𝐒𝐿I's and Smith when both of them are extra-articular? The displacement. So whenever there is a fracture, it gets displaced because of this muscle attachments, right? So these displacements will differentiate the names of the fractures. So whenever this displacement goes onto the dorsal aspect, it is called as the 𝐒𝐿I's fracture. And when the displacement is to the ventral aspect, it is called as the Smith's fracture, right? Yes. Yes. Montegia fracture, yeah, pin is the nerve which gets injured. Yeah, that is also very, very important. So 𝐒𝐿I's and Smiths we have done. This is extra-articular fracture. The displacement is onto the dorsal is 𝐒𝐿I's, ventral is Smith, right? And then what is Barton's then? Now, this Barton's is an intra-articular fracture and it is of two types. It could be a dorsal Barton's or a ventral Barton's, right? So this could be of two types. It is called the dorsal Barton's or the ventral Barton's. But when it is extra-articular and the displacement is dorsal, the specific name is given to it. It is called the 𝐒𝐿I's fracture. And when this particular displacement, extra-articular fracture goes onto ventral aspect, it is called as Smith's fracture. That you have to remember. Yes, the treatment of Montegia is, yes, it is open reduction and internal fixation. Why you think it is an open reduction and internal fixation? Pratyusha, can you answer? Why do you think it is an ORIF with the for Montegia? So here Pratyusha has told us this is an open reduction and internal fixation, right? So can you just answer me why? Because only because you have answered ORIF, I'm asking you why. Okay. So keep thinking. Yeah. So here, one more important thing is, yeah, 𝐒𝐿I's fracture is supposed to be an extra-articular fracture, as I've told you. Yeah, it is most commonly seen in your post-menopausal women. That is in case of osteoporosis. So most common fracture is osteoporosis, right? Osteoporosis. In children, extra-articular fracture, dorsal displacement. Yeah, correct. Volar displacement, then space fracture. But why are we worried about this dorsal displacement and ventral displacement? That does any role to us? That does mean anything to us? Or simply for the exam sake, we are learning that dorsal or ventral? Yes. How does this help to us? So it helps in aids in reduction. So once you understand the displacement, then you can reduce it, right? So when you know that this is a Colles fracture and the fragment has gone to dorsal, then when you are reducing it, you will try to put that fracture neutrally by putting the pressure on the dorsal aspect, right? You will try to bring the fragment from the dorsal to the neutral position. Similarly, when you know that this is a ventral displacement, you will try to reduce it from the ventral to the neutral position, right? So for the treatment purpose, you have to understand whether this is an extra-articular fracture or the intra-articular fracture. Again, why? So extra-articular fracture is you can treat it conservatively sometimes. So extra-articular, if the fracture is extra-articular, you can go for conservative treatment. And how do we treat the Colles fracture? We put up a cast which is called as Colles cast. So how do you do this Colles cast? What is the method? So first you give traction. Yes, traction, counter traction. Then what you do? You will do palmar flexion and ulnar deviation. Palmar flexion plus ulnar deviation. So this is how you reduce the Colles fracture. So that is why you have to understand by seeing the x-ray, by reading the x-ray, you have to understand whether this is a Colles fracture, that is whether it is an extra-articular fracture or an intra-articular fracture. So when you see it as an intra-articular fracture, you have to go for open reduction and internal fixation. That we do treated by opening, that is we go up to the fracture site, up to the radius, distal radius, and fix it with radius plating. That we do plating, distal radius plating. And why did I say radius plating? Why did not I use a nail here? Because we have two types of implants, right? We have nails and we have plates. So we have anytime whenever you want to do internal fixation, that means you're going to fix the fracture by surgery. There are two types broadly divided. The implants are divided broadly into two types, nails and plates. So here I have already committed that I'm going to take a plate for this distal radius fixation, right? Can somebody tell why I'm using plate here? Why not a nail? Because this fracture is a periarticular fracture. Whenever the fractures are periarticular, that means around the joint. That means around the joint, if any fracture is there, then we have to go for absolute reduction. We have to go for absolute reduction. That reduction is achieved only by plates. So whenever somebody is talking about periarticular fractures, absolute reduction, that means they don't want any callus formation around it. So then they will go and fix that fracture with plates. And whenever you are in need of callus formation, please remember, whenever you need callus, whenever you're going for a relative stability, you go for nails. So very, very important, because you people are understanding up to this. I even want to tell you about the implants also at this point, right? Yes, we are going for traction, counter traction, and palmar flexion and ulnar deviation. So that is very right. That is about the casting. So this is conservatively we are treating. Now I'm talking about the surgical treatment. Surgical treatment, when will we go for surgical treatment? We go whenever it is an intra-articular fracture, periarticular area. We want to fix it with absolute reduction. So we are opting for radius plating. So that is the that completes whole of your wrist fractures, right? So what is a Barton's fracture? So what would be the treatment of Barton's fracture now? Can somebody answer the treatment of Barton's fracture? Quickly. Treatment of Barton's fracture. So as I've told you that it is an intra-articular fracture. Now we have to go for what? For Barton's fracture, we have to go for a radius plating, right? So you have to go for distal radius plating. So the answer for the treatment of Barton's is plating, right? Now, what is Bennett's and Rolando? What is Bennett's and Rolando? Again, these are names given to the fracture of, yes. So Bennett's and Rolando is, so B for bi. Bi is 2. Whenever there are 2 fragments, fracture of first MCP, right? So first metacarpal, then that is your Bennett's. Rolando is tri. Rolando is nothing but tri, which is a comminuted fracture. Comminuted fracture of base of the thumb or the first metacarpophalangeal joint is your Rolando, right? Yes, the first metacarpal base fracture. So these are first metacarpal base fracture. So there are 2 important fractures which you have to remember. One is Bennett's and the second one is Rolando. So Bennett's is bi, so there are only 2 fragments. So if you think this is your metacarpal and now there is a fracture which is dividing only into 2 fragments, then that is your Bennett's. And similarly, if there is a metacarpal like this and there are multiple fractures, right? So there are multiple fragments 1, 2 and 3, then that goes for your Rolando, right? So those 2 are important, Bennett's and Rolando. Then what is Boxer's? Boxer's fracture is again, it is a fracture of 5th metacarpal neck. So 5th metacarpal neck fracture is your Boxer's fracture. So how this fracture happens? Whenever you use the fist, whenever you use a fist to punch onto the wall or punch somebody, then there will be fracture neck of the 5th metacarpal. That is your little finger. Little finger, that is your 5th metacarpal fracture neck, that is Boxer's fracture. Yes, there is, yeah, abductor pollicis, APL, abductor pollicis longus keeps pulling your Bennett's fracture. That is the smaller fragment, right? So sorry, the larger fragment. The larger fragment, I have told you there are 2 fragments, right? So the larger fragment will be pulled by your abductor pollicis longus, and whenever there is this pull, again it is an, remember, Bennett's and Rolando, these 2 are again intra-articular. Both are intra-articular fractures. Both Bennett's and Rolando are intra-articular. Pratyusha, nails and plates, you want me to repeat? Okay, Boxer's is 5th metacarpal neck fracture, right? Okay. Then what is Schoffer's fracture? Schoffer's fracture is isolated radius styloid process. So if you remember, there is a styloid process for radius, and whenever there is a fracture of this radius styloid process, isolated fracture. And please remember, this is also an intra-articular fracture, right? So the word intra-articular is very for Barton, as it is intra-articular fracture. Yeah, for Bartons, not nails and plates. You have to use only plate because it is a articular, peri-articular. That means we are dealing with the joint space, right? So this distal radius is nothing but it forms joint. Wrist joint is formed by the distal radius. So whenever you're treating this distal radius fractures, you have to be very particular that the joint line is maintained. So you have to always go for plating. There is no role for nails, right? So only plate is useful there, right? So that is about the nails and plates. Now we are done with Bennett's and Rolando. So please remember, both of them are intra-articular fractures. What is the difference is Bennett's, you have to go for absolute reduction because again it is an intra-articular and there is only 2 fragments, and because of the pull of the muscle, that is the abductor pollicis longus muscle pulls 1 fragment down, so there will be no chance of the union, right? So for that you have to open the fracture and you have to fix it, right? For Rolando, as it is a comminuted fracture, you can still go for a conservative because there are multiple pieces of the bone, you can't fix them properly, so still you can try for a conservative treatment. Again, Boxer's fracture is a fracture neck of the 5th metacarpal. Here the treatment is K wires. So K wires are the small wires which are very small, which are at the 1 mm, 2 mm, 3 mm K wires will be there, and you pass this K wires through the fracture, and hence you can give the fixation, right? And then we are dealing with Schoffer's fracture. So first fracture is radius styloid fracture, isolated radius styloid. So you remember the radius styloid. The radius styloid is also a part where it enters into the joint. So you have to be very, very clear that this fracture is an isolated radius styloid fracture, right? And then die punch fracture. What is this die punch fracture? Die punch fracture is again an intra-articular fracture, but here the fracture is at the lunate fossa. Lunate fossa, right? So if you see, how is the wrist joint formed? Wrist joint is formed with both scaphoid and lunate. So distal radius, the distal end of the radius articulates with the scaphoid and the lunate. So whenever there is a fracture which is extending into the lunate fossa, that is called as the die punch fracture, right? So whenever the lunate fossa is involved, it is called as the die punch fracture. So those are the various names, or which are called the eponyms of the upper limb fractures, right? Now let's go to the next table. So this is second table. This is about the lower limb fractures. So this is about the lower limb fractures. I hope the upper limb is clear. So now let's go with the lower limb fractures. So lower limb fractures, I have started first with the, so these three are the pelvis fractures, right? So these three are the pelvis fractures. So what you have to remember is pelvis. You know, this pelvis is formed by two hemipelvises, right? So we have one hemipelvis where there are three parts for it. So it is the pubic part, the iliac part, right? And the ischium part. And here also you have the second hemipelvis. You again have the ilium, ischium and the pubis. And now these two hemipelvis are connected by one single bone, which is called as the sacrum, right? So now you have to always remember, whenever you're dealing with pelvis fractures, you have to always remember that the pelvis is a ring-like structure which is connected anteriorly by pubic symphysis, that is, let us write as PS, and posteriorly it is connected by sacrum, right? So this is posterior, this is anterior. So anteriorly by pubic symphysis, posteriorly by sacrum. And here if you see, there are three structures: pubic, ilium and the ischium somewhere here. So pubis, ilium and somewhere here ischium. So now whenever you're reading the pelvic fractures, you have to comment how is first the ring, whether the ring is secured. That means whether the fracture is only present in one hemipelvis or it is present in the two hemipelvis, like both the pelvis are injured, or sometimes it might present anteriorly and posteriorly together. So that is how you keep reading the x-ray of the pelvis, right? So here, based upon that, they have given names to it. So whenever I say Duvernay's fracture, the second one, not the first one, Duvernay's fracture, it is nothing but an isolated iliac wing fracture. It is nothing but an isolated iliac wing fracture. That means if I go back to the basics again, that is the ring. So here I have told you that there is an isolated ring fracture. So if you imagine the pelvis as a round-like structure, so this, let us take the example of this pelvis here. And now I told you this is an isolated iliac wing fracture. So is this disturbing the ring? So I have told this is the pelvic ring and this is iliac wing. Don't get confused with ring and wing. So this is wing, iliac wing fracture, right? Now this is the fracture. Now tell me whether this ring is getting disturbed. No, right? So this is an isolated something. It is present in the hemipelvis, but it is not disturbing your ring. So whenever the ring is not disturbed, that means it is a stable pelvic fracture. It is a stable pelvic fracture. Yes, Duvernay's is such a stable pelvic ring fracture, which is an isolated wing fracture. Very good. And next, coming to the 𝐒𝐿-Gagnè's fracture. So what is a 𝐒𝐿-Gagnè's fracture? 𝐒𝐿-Gagnè's fracture is fracture both in the anterior aspects and posterior aspect. That is also ipsilateral hemipelvis. In the ipsilateral hemipelvis, if you see, there is a fracture in the anterior aspect and the posterior aspect. then that is called as 𝐒𝐿-Gagney's fracture. So now let's get back to the ring here again. So here I have told you what is 𝐒𝐿-Gagney's fracture. What did I tell you about it? So there is a fracture anterior aspect. So now let us assume there is a fracture here on the anterior aspect and there is a fracture in the posterior aspect. So one part of the hemipelvis is damaged. Hemipelvis is damaged. That means there is no problem in the opposite pelvis, but only one side of the pelvis is damaged, anteriorly and posteriorly. Ipsilateral pelvis is damaged. So that is your 𝐒𝐿-Gagney's fracture, and that is because of the vertical shear, and this is some sort of unstable fracture. So this is unstable fracture, right? If you see the ring here, it is disturbed anteriorly and posteriorly. So ring is disturbed anteriorly and posteriorly, but still it is vertically stable because only one side of the ring is damaged, right? So this is a type of vertical shear fracture, and it is an unstable fracture, and it is called as the 𝐒𝐿-Gagney's fracture. What is this crumbled paper? No for what? So that is about the 𝐒𝐿-Gagney's fracture. So ipsilateral anterior and posterior fractures is called as the 𝐒𝐿-Gagney's fracture. Now what is bucket handle fracture? So similarly, when we come back to bucket handle, it is also fracture of the ring anteriorly and posteriorly, but it is on the contralateral pelvis. It is on the contralateral pelvis. Again, go back to this similar picture. So when I say there is a bucket handle fracture, so that means there is a ring which is present here, and now this fracture has happened anteriorly in one pelvis and posteriorly in the opposite pelvis. So whenever it is in the opposite pelvis, that is contralateral pelvis, then that is called as the bucket handle fractures, and this is called as the bucket handle fracture. Understood? So these are three types. You have to remember the Duvernay's, the 𝐒𝐿-Gagney's, and the bucket handle fracture. So bucket handle is contralateral, so opposite pelvis. 𝐒𝐿-Gagney is ipsilateral, that is same side. Same, but what you have to remember is on the anterior and the posterior aspect of the pelvis. So I will draw here. So this is anterior, posterior, same side. So white one is 𝐒𝐿-Gagney, green one is your bucket handle fracture. Hope it is clear? Yes or no quickly? So now let's go back to one more fracture. Okay, now we are done with the pelvis. What is bumper's fracture? What is bumper's fracture? Bumper is nothing but a car bumper. So a car bumper will come and hit you at the knee, right? So usually it is the lateral side which is mostly exposed, right? You can't hit somebody on the medial aspect of the knee because it is inside. So lateral condyle fracture. It is a lateral condyle fracture of tibia, right? That is called as the bumper's fracture. So this is about the knee joint where there is a lateral condyle fracture of the tibia. It is usually the comminuted fracture. So that is your bumper's fracture. Yeah, what is pelvis open book? Very good. So now similarly, if we have this ring like this, right? So ring like this. And now I have told you the bucket handle fracture. If you remember, I've told you the bucket handle fracture is this way and this way, right? So what happens is if this pubic symphysis, if the ring is unstable, if there is a fracture which is happening on the two sides and the ring becomes unstable, then the pelvis opens, right? So there is a damage to the ring on the anterior aspect and the pelvis open. That is called as the open book fracture, right? So that is again a form of unstable fracture. So there is a damage to the pelvis ring. So there is a multiple fractures happening in the pelvic area. Probably it could be a 𝐒𝐿-Gagney fracture. It could be a bucket handle fracture. Now what happens is because of this instability, the pelvic opens. So then what you have to do, the immediate management of is it you have to put the pelvic binder. You have to put the pelvic binder. This was asked in your NEET exam last time. Where do you put the pelvic binder? So why are you putting this pelvic binder? You're putting the pelvic binder to close the pelvis, right? So now because there is a fracture which is happening in the pelvis, which is causing an unstable ring and causing the pelvis to open. Now it is a closed ring. Now because of the fractures, there is some gap, and because of the instability in the ligaments, the pelvis becomes open, which is called as an open book fracture. And now how do you treat it? You treat it with the pelvic binder. It is an emergency and absolute necessity. You have to identify it, right? And so now you're in the emergency casualty, you don't have an orthopedic surgeon with you, and you don't have a pelvic binder, because usually they are not available in the casualty. So now what you will do? What you have to do is, you can take a bed sheet. You can take a big bed sheet and you have to tie that bed sheet tightly. Which level you will tie this? At the level of greater trochanter. So now you will identify the greater trochanter on the pelvis. So you can identify right on the lateral aspect. You can find a bony prominence which is called as the greater trochanter, and that area you will put the bed sheet and you will put a tight knot, like you are putting a laundry. Whenever we put all the clothes in the laundry in a big bed sheet and we'll tie, right? So similarly, you have to tie that pelvis like that. So why should you tie this pelvis? Because there will be vessel injury. Whenever there is a pelvic fracture, there is a chance of vessel injury. So whenever you tie this bed sheet tightly, that will act as some support to the vessel, so it will stop bleeding, right? So these pelvic injuries are very grievous and they may lead to death directly, because of the which vessel? The internal iliac vessel and the sacral vessel. So these two vessels are at danger whenever there is a pelvic fracture. So these are prone for damage, vessel injury. So you are protecting these damages, right? Or excessive bleeding. Yeah, tamponade effect. Very good. Thank you. So that's the tamponade effect, right? Very good. So that is about the pelvic fractures. Now let's go back. We have dealt with the bumpers fracture, that is the lateral condyle fracture. Very good. And then we are dealing with Pott's and Cotton's fracture. So now we are going to the ankle fractures. So ankle fractures, there are two important fractures you have to remember. One is Pott's fracture. The second one is the Cotton's fracture. Can now you tell me what is Pott's and what is Cotton's? So Pott's is a bimalleolar fracture. Pott's is a bimalleolar fracture. If you remember, ankle has two malleoli, the medial malleolus and the lateral malleolus. Right? So whenever there is a fracture of these two malleolus, it is called a bimalleolar fracture. And not to forget, there is one more malleolus which is called as the posterior malleolus. So this medial malleolus is to the tibia, and now you have one more malleolus I have told you, that is your lateral malleolus. So this is your medial malleolus, and for the fibula you have the lateral malleolus. Now where is this posterior malleolus? Posterior malleolus is again on the posterior aspect of the tibia, and you can see this only on the lateral view. So now you have to go for two views in case of your ankle. So now this is called your AP view, where you see the medial malleolus and lateral malleolus. And now this is called your lateral view, where you can see the posterior malleolus on your posterior aspect. And whenever you see all the three malleolus get fractured, so that is called your Cotton's fracture, that is trimalleolar ankle fracture. So remember, Cotton's is bimalleolar, Cotton's is trimalleolar, right? So that is how you have to remember. And remember, there are three malleolus in the ankle: medial, lateral and posterior malleolus. Then what is Lisfranc's? So now we are done with the ankle, we are going to the foot, right? So what is Lisfranc's fracture? Lisfranc's is tarso-metatarsal, right? So if you remember foot, we have two things, right? So we have talus, then we have the big one, calcaneum, and then we have navicular, cuboid, then we have three cuneiforms, and then we have your metatarsal, right? So whenever this tarso-metatarsal, so these are called the tarsals, these are called the metatarsal. So whenever there is a fracture or dislocation of this tarso-metatarsals, so tarsal bones with the metatarsal, that junction, whenever there is a fracture, that is called as the Lisfranc fracture. That is tarso-metatarsal fracture dislocation is your Lisfranc fracture, right? Very, very important. These are all just like the one-liners. You can easily score the marks here. So if they ask you bimalar fracture is potens, trimolar is this potens, sorry, bimalar is POTS, trimolar is potens, then you have tarso-metatarsal fracture dislocation, then it is Lisfranc's fracture, right? Then what is aviatas? Aviatas is fracture neck talus. So fracture neck of talus is your aviatus fracture. So now recently they have asked you what is the classification of this. So it is the Hawkins classification, right? So this is the Hawkins classification which we give for fracture neck of talus. Then what is Jones fracture? Jones fracture is fifth metatarsal base fracture. Fifth metatarsal base is Jones fracture. Now can somebody tell me what is March fracture? What is March fracture? Pratyusha, Sakshi. Yeah, very good. Whenever there is an increased gap between first and second. So whenever there is a fracture of Lisfranc, no, here, this is the sign. So when you see there is an increased gap between first and second metatarsal, this gap is an indication or telltale sign for us to identify the Lisfranc fracture. Very good. Crumbled paper, very good. So this is, can you tell me your name? It is like, you know, I am not comfortable calling you crumbled paper, crumbled paper. So now there is a gap. This gap is seen between the first and second metatarsal on the X-ray. So this, whenever there is a huge gap, you know, then you have to always suspect for your Lisfranc fracture dislocation. Raj, okay. Okay, Raj, what is March fracture? Second and third metatarsal. So March fracture is usually second metatarsal neck fracture. Neck fracture. So where do you see this March fracture? So usually we see this as a form of stress fracture. So what is a stress fracture and what is a pathological fracture? So let us just understand what is a stress fracture, what is a pathological fracture. I've told you that March fracture is an example of your stress fracture, right? So second metatarsal neck fracture is your March fracture, I have told you. So here what happens is in the stress fracture, the bone is normal and there is continuous abnormal forces which are acting, which are resulting in the fracture. So the bone is normal. There is a continuous abnormal force which are acting on that particular area, like your neck area of your second metatarsal. Okay, so this continuous forces will result in the stress fracture. What is pathological fracture on the other hand? The pathological fracture here, what you have to remember is the bone is abnormal. The bone here is abnormal. That means the bone here is not normal. So even small amount of force or the trivial trauma will result in fracture. So the important key point here is force which is acting here in both stress and pathological fractures is trivial. That is minimal force on both the bones. But in one case, the bone is normal. In other case, the bone is abnormal. So this pathological fracture you have to identify mostly in case of your metastasis, right? So any infections or any inflammation. So you have to always think in terms of this. So while looking at the X-ray, if you think, while looking at the X-ray, if you think that bone is not normal and if the patient is presenting with the fracture, then you have to always evaluate for metastasis, infection or inflammation, right? So that is how you come to the diagnosis. So sometimes the patient just will come to you and with trivial trauma means just a small, you know, they'll just slip and they'll fall and they'll result in a great fracture. So that is how you have to be very sure whether you're dealing with the normal bone or an abnormal, right? So that is the difference between stress fracture and the pathological fracture. Pathological fracture, tenderness present, yes, it will be present. It will present you like the normal fracture, right? But see, the symptoms will not be that grievous. In case of pathological fracture, what happens is once the fracture is very evident, like with lot of displacement, if it is especially in the lower limbs, the patient will come with mild pain, and then he will tell that he's unable to walk, and tenderness will be present. And now when you go for the x-ray, you will see that sometimes you might be mistaken it as, this tenderness could be because of some just a small bone edema or the soft tissue injury, because they will not tell you that grievous injury. And we only suspect fractures with the grievous injury, right? So even with the minimal force also, there is a high chance of this bone resulting in fractures. So when you order for an x-ray and when you see that the bone is abnormal, then you have to always suspect for a pathological fracture. In stress fracture also, because of their history, so once the patient comes and tell you there is a pain in your foot, and he will tell you, then the first question what we ask is there any trauma? Then they'll tell you there is no trauma, there is no injury, there is no fall. Then usually we think this could be a soft tissue injury, but you have to again examine clinically, tenderness will be present, and then you have to ask them about this stresses. So whether they are working continuously, whether they are doing something else other than normal activity, and then when you order for the x-ray, you will see fracture there. And yeah, the investigation of choice is always MRI. Why? Because the stress fracture will always start with first the marrow, which is getting damaged there, and then the cortices will be evident. So because the marrow is damaged first, you can identify that in MRI. Always remember, whenever you want to identify the marrow related problems, you have to go for MRI, and whenever you want to identify the cortex related problems, you have to go for CT scan. So as you are used to your mnemonics, marrow is M, C, that is cortex is CT scan. This is very, very important, and it will help you for knowing the investigation of the choice, right? Okay, now last one, the 𝐒𝐿𝐽𝑒𝐿 fracture. So what is a 𝐒𝐿𝐽𝑒𝐿 fracture? So what is a 𝐒𝐿𝐽𝑒𝐿 fracture? Raj, Pratyusha, what is a 𝐒𝐿𝐽𝑒𝐿 fracture? So here, what is a 𝐒𝐿𝐽𝑒𝐿 fracture? Yeah, this is an avulsion fracture. Avulsion fracture. Avulsion fracture of the distal tibia because of the anterior tibialofibular ligament. So whenever I say an avulsion fracture, so what does that mean? That means there is some ligament or tendon which is attached to that bone, and now that particular area got pulled off from that bone. So that is the actual meaning of your avulsion fractures. So similarly, this 𝐒𝐿𝐽𝑒𝐿 fracture, which is usually seen in case of children, because children, the ligaments are not that strong, right? So in children, what you do, ligaments are very strong. So usually we don't find any ligament injuries or dislocations in case of children. We usually find the bone injuries, right? So what happens in the 𝐒𝐿𝐽𝑒𝐿 fracture is, this is the avulsion fracture. So this is called the avulsion fracture. So whenever I say the word avulsion, that means there is some tendon or some ligament attachment to the bone is involved, right? So ligament is usually attached to the bone, right? So here what happens is there is an anterior tibiofibular ligament which is attached there. Now that is pulling your part of a bone. Because of this ligament, there is a fracture, that is avulsion fracture, which is called as the 𝐒𝐿𝐽𝑒𝐿 fracture. Understood? So this is about the various fractures both in the upper limb and the lower limb. Hope I have completed most of them. Now coming to the very important spine fracture. So these are all again the spine fractures. So starting with the spine fracture, let us start with the Jefferson's fracture. So what is the Jefferson's fracture? Jefferson's, F for first. So first is C1. If you remember, this is an arch-like structure, right? So this is an arch-like structure, and whenever there is a bilateral arch disruption, so that is called your Jefferson's fracture. Remember, F for first, there are two F's. So it is a bilateral arch fracture. So similarly, like your pelvic ring-like structure, I've told you, similarly, this is arch-like structure, and there is bilateral disruption of this arch, which is resulting in fracture. This is called as the Jefferson's fracture. Yes, C1. Remember, C1, cervical 1. Then what is a chance fracture? What is a chance fracture? Is that occurring by chance? Chance fracture is a type of seat belt injury, very important while dealing with your polytrauma, and other name given to this is your flexion distraction injury. So what happens is, because of that seat belt, flexion and distraction, so they have put up the seat belt, right? So because of that, there will be a grievous injury that is called as a flexion distraction injury of the spine, which will result in an horizontal fracture of the vertebra. Horizontal fracture of the vertebra. So now let me tell you, do you know this Dennis-Brown concept? Dennis-Column concept? Yeah, it could be a hyperflexion and then will be a distraction. Or because of the seat belt, there could not be a more of hyperflexion, but distraction element is important here. Yeah. So can somebody tell me, do you know this Dennis-Column concept? So Dennis-Column concept is nothing but this particular spine or the vertebra is divided into anterior, middle and posterior. 3 columns. So anterior column, middle column, posterior column. Right? So whenever there is a problem in this posterior column, it is very important for us. So posterior column is very important for us because the nerve are traveling in this posterior column. So this is supposed to be an unstable fracture whenever it involves the posterior column, So chance fracture. So this is an example of a chance fracture where you see the fracture is horizontal and it is extending into the posterior. So you can see all the 3 columns, the anterior column, the middle column and the posterior column is involved, and this is a highly unstable fracture. What you have to remember is flexion distraction is the mechanism of the injury, and what you see on the X-ray is a horizontal fracture. So for your, yeah, very good. That is the Dennis. Very good. Horizontal fracture of the vertebra is your chance fracture. Then what is burst fracture? What is burst fracture? Burst fracture is compression. Vertical compression fracture is burst fracture. So just imagine your vertebra is blowing out. So multiple fragments, like it is just like a multiple comminuted fracture. That is your burst fracture. It is a compression fracture, that too like this. So if you're putting something like, imagine a cake and now you're pressing it like this, what happens? It will, blow out like this, right? So that is the burst fracture. Then what is 𝐒𝐿-Chauberlet's fracture? 𝐒𝐿-Chauberlet's fracture is a very simple fracture of the spinous process, of C6 or C7, right? So these are the lower areas, right? Lower vertebra. You remember it as lower vertebra, right? So spinous process of C7, C6, lower vertebrae, only the spinous process area. Whenever it is fractured, this is called as a 𝐒𝐿-Chauberlet's fracture. Then what is hangman's fracture? What is hangman's fracture? Hangman's fracture is C2. C2, what happens if you remember, the C1 is the arch-like structure, right? And C2, if you see, there is some, what is this called? The odontoid process. So this is called as the odontoid process. So there is one process which is attached to the C2. This is called as the odontoid process, right? So whenever there is again damage to both the pedicles, if you remember the vertebra, the parts of the vertebra, there is body, then there are pedicles, then there is a transverse process on both the sides, and then there is a spinous process. right? So that is the structure of the vertebra. In that vertebra, if there is a fracture of both the pedicles resulting in traumatic spondylolisthesis of C2 over C3. What is spondylolisthesis? Forward movement of the upper vertebrae over the lower vertebrae. That is called as spondylolisthesis. So just remember, the hangman's fracture is spondylolisthesis. That is again traumatic spondylolisthesis of C2 over C3. That you have to remember. So traumatic spondylolisthesis of C2 over C3 because both the fractures, the pedicles. So now what you know is one vertebrae is stacking over the other vertebrae, right? So if you see, both the vertebrae are like this. And now what happens is this vertebrae is moving forward. So why it is moving forward? This is called as listhesis. The forward movement of upper vertebra over lower vertebra is called as listhesis. This movement, forward movement, is because the attachment, the pedicles are strongly holding the body. Now both the pedicles are damaged. That is why this is moving forward. So whenever there is both the pedicles which are damaged in the C2, right, and now the C2 is able to move forward over C3, then that is called as hangman's fracture. Simple fracture of the odontoid process, simple fracture of the odontoid process is called as the dense fracture. Simple fracture of this odontoid process is called as the dense fracture, right? And now, which is the most common one? Do you see dense fracture commonly or hangman's fracture commonly? So the most common fracture in C2 is dense fracture, right? So dense fracture is the most common one. Yeah. Then what is the undertaker's fracture? Right, Pratyusha, you're right. What is the undertaker's fracture? So undertaker's fracture is, dense is most common. Very good. Okay. So what is undertaker's fracture? Undertaker's fracture is something which is seen in post-mortem. So a post-mortem, what happens is this body, whenever they transfer this corpus or the body, mishandling of that body will result in damage to the intervertebral disc of C6 and C7. So whenever this damage occurs in the disc of C6 and C7, that is called as undertaker's fracture. Dense fracture is most common. Yeah, dense fracture is most common. So undertaker's fracture is nothing but this is usually the autopsy finding where they see there is a damage to the C6 and C7 vertebra resulting in crushing of that intervertebral disc. And this you have to remember because this could not be any evidence for any injury or any assault of that particular person. This is just an fault. You have to interrogate the people who have transferred this body, and they will let you know that they have suddenly dropped it or suddenly hit it to a wall or something has happened while transferring this body. So now you will see this is known as the undertaker's fracture, right? So yeah, mishandling of the body is your undertaker's fracture. So that completes the spine for you. We are down with 3 tables, right? And now the 4th table. Now this is very easy, nothing to explain, just to remember. This is like the facts, you have to read this before going to exam. And those are a little bit of concepts, right? So you can read it 2 days before the exam, right? So now what are the classification names for that particular fractures? And remember, these are the areas which will give you marks, right? So you can, if you read, you will write. That's it. There is no understanding or concept building behind this. So what is the classification name for given to classification of clavicle? This is Allman's classification. So whenever you see the name which is given to classification of the clavicle, it is the Allman's classification, which is used for clavicle fractures. Then proximal humerus fracture, very, very important, Neer's classifications. So Neer's classification, so this one thing I want to tell you that Neer is the person who has divided proximal humerus into 4 parts, right? So he has divided proximal humerus into 4 parts. So the greater tuberosity, lesser tuberosity, right? Yeah. So these are the 4 parts, and whenever there is a damage to this part, right? GT, LT, head, and shaft. So whenever there is damage to the 4 parts, it is called as a 4-part fracture. That is what you have to remember. So NEER is the one who has given this classification, right? Proximal humerus, NEER's classification. Supracondylar fracture, Gartland classification, right? Supracondylar fracture is Gartland's classification. Lateral condyle fracture is Milch. Yes, lateral condyle fracture is Milch classification. Then Montigia is Bedo. Montigia is Bedo classification. Radial head is Mason. Mason classification, right? I'm going little fast, okay? This is just names you have to remember. Next, pelvis. Pelvis, you have to remember there are two. One is Tile classification. The second one is Young and Bugres classification. Young and Bugres classification. Just remember, radial head is Mason. Montigia is Bedo. Lateral condyle is Milch. And supracondylar is Gartland classification. Okay? But pelvis, there are two, Tile and Young and Buttress. Then acetabulum is Letournel and Judet classification. If you remember, we have Judet views also for acetabulum. So whenever you see the fracture of the acetabulum, you have to go for special views. Those are called as the Judet views, right? And then fracture head of the femur. Be very particular whenever they're talking about the head fracture in case of proximal femur, then that is your Pipkin's classification. Whenever they are talking about the neck fracture, so please remember, whenever it is neck fracture, there are two. One is the Gardner's classification. The second one is your Powell's classification, right? So for neck, we have two, Gardner's classification, Powell's classification. But for the head, we have one, that is Pipkin's classification. Do not confuse, because the first option will be Gardner's, and you will see fracture femur and you will go for Gardner's. Read the question carefully. If it is head, you have to mark Pipkin's. If it is neck, you have to mark the other two. Yeah, Judet views are for acetabulum. Very good. Shaft femur. Now, shaft femur, we have Wiedequist and Hassen's classification. Wiedequist and Hassen's classification, right? Yeah. Wiedequist and Hassen, that is shaft femur. Then talus, you have, this was asked recently. So this is an exam PYQ. So that is your Hawkins classification. For talus, neck especially, this is talus, neck, we have Hawkins classification. And for calcaneum, what is important for you is your Sanders classification. And this is a CT based classification. There is one more name which is called as the Essex Lopricette. Essex Lopricette is a classification name which is X-ray based in case of calcaneum, right? It is Essex Lopricette. Essex Lopricette, right? Very good. Pratyusha, are you planning to take ortho by any chance? Yeah, so that completes the fractures classification names. So we have learned many names. Just what you have to remember is keep reading them. That's it. No mnemonics, nothing for this. And you have to just keep reading. Talus, Hawkins, very, very important. If you don't want to remember anything, remember this. Talus, fracture neck of femur, and probably acetabulum maybe, right? So Gartland anyways you will remember, right? Because it is very, very important. You got used to it. So you will remember the supracondylar is Gartland's. But still, if you want to remember a few, then you go for acetabulum or neck and talus, Hawkins. Okay, we'll discuss that later. Why no? We'll discuss it later. Okay, now we are done with the classification names. Yeah, even I think so. She have already done PG in ortho. Okay, now next what we are going to learn is this. This is very, very important. Now get back. This is really important because these test names, they will definitely ask you. So there are two important areas. One is knee. The second one is shoulder. So here you have to remember there are certain things like the ligaments, the important structures around the knee joint. You have two ligaments. One is anterior cruciate ligament, posterior cruciate ligament inside. That is, in intra-articular. And now we have extra articular, that is MCL and LCL, and we have two meniscus, medial meniscus and lateral meniscus, right? So these are the structures. And whenever a patient comes with the knee pain, without any fracture, you have to diagnose which ligament or which structure has been damaged clinically. Nowadays, we got used to it and we are sending patient directly for MRI. But before that, clinical examination has to be done, and you have to write on the prescription that which area you're suspecting more. That becomes easy for the radiologist to examine that part in more detail, right? And next, in the shoulder area, again, we have four important structures. These sit muscles that you have to examine whenever a patient comes for the shoulder pain, right? Without any fracture. So this area is called sports injury. So sports medicine is mainly based upon these structures, right? So let us go back and revise what are the tests for ACL, the anterior cruciate ligament test. So the cruciate ligament test is first one, very, very important. That is your anterior drawers test. So anterior drawers test. So how do you do this? We all know, because it could be an image based question. So you have to be familiar with it. So now you make the patient sleep, that is supine position. And then what you do is you flex the knee up to 90 degrees. So please remember, whenever somebody is doing anterior drawers test, the knee should be in flexion of 90 degrees. Very, very important for performing this test, right? And now what you're doing is you put your, like this, you put your hands around it. So this fingers will go on the posterior aspect and your thumb will be on the anterior aspect. And now what you do is you try to pull the tibia forward, right, towards the thumb side, right? Why are we trying to do this? Because we know that anterior cruciate ligament limits the forward translation of tibia over the femur. That is the work of the ACL, right? So what is the work of an ACL? It will limit the movement of tibia anteriorly. So whenever there is a damage to this, what will it do? It will allow it, right? So whenever there is a damage to the ACL, what will happen? When you're trying to pull the tibia forward, it easily comes forward, right? If ACL is intact, you can't pull it that easily. So that easiness you can find it when you compare it to the opposite side. So that is your anterior drawers test, right? So that is your anterior drawers test is for your ACL, that is anterior cruciate ligament. Very easy, anterior and anterior. What is the second test? So now imagine this patient who is coming to your OPD is with full of pain. There is a lot of swelling, pain, and he's unable to do this 90 degrees flexion. So now how will you test him? So without testing, you can directly send to MRI, because the radiologist will ask you, where is your, what do you think is the problem and why are you actually prescribing MRI for this patient? So now without flexing to 90 degrees, you have to tell that there is an ACL tear. So now what you do? You take the help of Latchman's test. So Latchman's test has been originally designed to identify your ACL whenever you can't flex it to 90 degrees. Here, what would be the flexion? It is just 15 degrees of flexion is enough. So whenever a patient comes with full swelling, full pain, you can just do 15 degrees. So now your position of your hands will be like this. And you will be holding the femur and the tibia, and now you do this type of translation. So now instead of doing this in 90 degrees, you do this. So when you are again feeling that tibia is easily pulled forward, then that is again a positive for your anterior drawers test, and this is called as your Latchman's test. Following Raj and Pratyusha? So this is called as the Latchman's test. And now the third one, the most specific test is your pivot shift test. Pivot shift test. Right? So there are three important tests for anterior cruciate ligament. So one is your anterior drawers, the Latchman's, and your pivot shift test. So pivot shift test is again, this is done as MCL should be present, and it is done against the MCL. So MCL, what you do? So MCL and this ACL will hold your tibia tightly. So whenever there is this ACL is gone or there is a tear in ACL, and now you try to internally rotate. So this what you have to do is you have to put the limb in valgus and then try to internally rotate. So now there will be a jump of this tibia over the femur. So that is called as pivot shift test, and this is very specific and usually done under anesthesia. So why I'm telling this as very specific test? So what happens is once we do this ACL reconstruction, right? So we have come across a patient who had an ACL tear and MRI is done. We have confirmed it and now we have performed a reconstruction. That means you have taken ligament from other area and you have constructed ACL. Now, how do you know that this ligament is actually working as an ACL? Now, what we do is we do this pivot shift test and anterior draws test to confirm. So, this pivot shift test is supposed to be the most specific. And this Latchman's is said to be most sensitive. I hope you all know what is sensitivity and what is specificity, right? So sensitivity is minimum of your any damage is identified. Specific is specific to that particular part, right? So that this is about your ACL. So anterior draw test, Latchman's and pivot shift test. And similarly, what is PCL? Test for PCL is posterior draws test. Posterior draws test, right? And then this is similarly to the ACL again. So ACL we are pulling it forward. Posterior draw test is you push the tibia backward because PCL again restrains your posterior translation of tibia. So whenever there is a posterior PCL is not present or there is a tear in PCL, you can easily push the tibia backward. So that is your posterior draws test. And what is your MCL for? How do you test your medial cruciate ligament? Medial cruciate ligament. So here you have stress test for this. You have to do a stress test. So one is valgus, the other one is varus. So MCL you do a valgus stress test and LCL you do a varus stress test. Nothing here. What you have to do is you have to just make that particular ligament tighten. So valgus is moving towards midline, right? You will varus is you move like this. So you're testing for the lateral aspect. Valgus is you move away from the body. So you're testing the medial aspect. So stress is on the medial side. This stress on the varus, the stress is on the lateral side. So each one is understood that way. So MCL, you go for the valgus stress test and LCL, you go for the varus stress test. Yes, Pratisha, right again. And how do you do the meniscus? Here again, we have two tests for meniscus. One is your McMurray's test. One is your McMurray's test is for meniscus. And then you have the Apley's grinding test. So one is the McMurray's test. The second one is your Apley's grinding test. What is McMurray's test? McMurray's test is again done in your 90 degrees of flexion. And now we try to internal rotate and external rotate. Both medial meniscus and lateral meniscus. So whenever you internal rotate the medial meniscus and whenever you external rotate the lateral meniscus is examined. Nothing of that sort is required at your level. Just remember that both medial meniscus and the lateral meniscus damage can be identified by McMurray's, and again both can be identified by Apley's grinding test. So what is the most important thing of Apley's grinding test? This is done in prone position. This is done in prone position, right? So you will put the patient in prone position and this limb you do it like the grinding. So you put vertical pressure on it and then you do your medial rotation and the lateral rotation. So that is called as your Apley's grinding test for meniscus. Now we are done with the knee. Now we are going to the shoulder. So shoulder you have supraspinatus, infraspinatus, teres minor and subscapular. Very, very, very important. So first one is your supraspinatus. As you all know, there is a scapula and there is a spine of the scapula on the posterior aspect, right? And above the spine is the supraspinatus. Below the spine is the infraspinatus on the posterior aspect. On the anterior aspect, you have your subscapularis, right? So why am I explaining it this detail is if you know what works in which direction, it will be very, very easy for you to remember. So let us take the example of supraspinatus. What did I tell you? This supraspinatus is present above the spine and where it is getting attached, it is getting attached to your greater tuberosity, right? So what is the work of this supraspinatus? I mean, what is the action of the supraspinatus? Answer. What is the action of the supraspinatus? Yes. So the action of the supraspinatus is abduction. So how do you test this? So now what you ask the patient is you ask the patient to do this empty can sign. That means you put the thumb upside down like this, and now you try it. Then tell the patient to abduct, complete extension, and then you try to abduct the hand. So because the supraspinatus hates in abduction. So this is the test which we examine in abduction, which is called as the empty can test. So this is the supraspinatus. What we do is we turn this like this and we try to lift the patient hand up against the resistance. The patient will try to lift it up, but against the resistance of the surgeon or the examiner. Now tell me, if this supraspinatus tear is present, will the patient will be able to hold the hand like this in air for a longer time? If there is a suspected supraspinatus tear, do you think the patient will have the ability to hold the hand like this? She can't hold it for a longer time. Hence, she will be dropping the arm. So this is called as the drop arm sign, which is again seen in supraspinatus tear. Understood? So supraspinatus is for abduction, and whenever you want to test the supraspinatus, what you have to do is ask the patient to put your thumb upside down. This is called as empty can, and try to abduct. So this is the test for your supraspinatus, and if the patient is unable to hold it for a longer time and dropping the arm, this is called as the drop arm sign. Okay, and then infraspinatus, as Pratyusha has already told, the lateral rotatus or the external rotation. So external rotation, because again the muscle is present on the posterior aspect and now it is attaching to the GT. So always the pull of the muscle is towards the origin, right? So the origin is on the posterior aspect. So now what will it do? So the infraspinatus and the teres minor, because they are present on the posterior aspect of the scapula, they try to pull the arms outside, the shoulders, they try to pull it outside. That is called as the external rotation. And this, whenever there is a tear in the infraspinatus, there will be external rotation lag. This is called as the lag sign. So lag sign is seen in both teres minor and infraspinatus injury, right? Teres minor and the infraspinatus injury, they use the lag spine. There is something which is very specific for teres minor. So teres minor, again, there is something which is very special, which is called the horn blower's sign. This is called the horn blower sign. So this blowing of the horn. So they can't do the external rotation and then they take this horn blower's position. So this is called as the horn blower's sign. And subscapularis, so we are done with the abduction, external rotation, and now internal rotation. So internal rotation, because again the subscapularis is present on the anterior aspect, right? So, and it is attached to the lesser tuberosity. So now this tries to pull it inwards. The subscapularis will try to pull the shoulder inwards. So that is the internal rotation. So we have two important tests. One is the belly press test, and the second one is lift off test. Lift off test is, again, what you do is put the patient's hand like this on the back, hope you can see, and try to lift this hand up. This is called as the lift off test, where you ask position, this is backward like this, and now you try to lift off. And then belly presses, you try to press the belly button with the both palms like this and try to do internal rotation. If they're able to do the internal rotation and if they're able to lift off the hand, so their subscapularis is intact. When they are unable to do this, this is called as the tear in the subscapula, right? And what is knee impingement test? What is knee impingement test and where do you see this? So this is for the impingement. Impingement is shoulder impingement syndrome. So what is the shoulder impingement syndrome? So there is some certain area which is called as a subacromial space, where there are certain structure passing through it, such as your supraspinatus, your biceps tendon, and subacromial bursa. So all these structures are present in that particular area. So whenever there is an impingement present in that particular area because of, supraspinatus tendinitis or subacromial bursitis, so there will be patient will have severe pain whenever he abducts. So now what you do is you abduct the arm and you internal rotate the arm. That is called as the knee impingement test. So there is an abduction, complete abduction. So there is a complete abduction of the arm, and then what you do is internal rotation. So this is for the knee impingement test. What are the structures you test here? So there are certain structures, as I've told you. They could be supraspinatus tendinitis, or subacromial bursitis. So these are all the structures which are present in the subacromial space. So these structures may lead to a problem which is called as shoulder impingement syndrome, right? So that test which we do here is knee impingement test, right? There is one more test which is called as Kennedy's test. Here also you abduct and flex it to 90 degrees with internal rotation. So that is again one more test, again for your impingement syndrome. So just remember, these are certain tests. Beer can and empty can, yeah. So there is no name which is given as beer can, but empty can is there. But if the word can is there, then it is your supraspinatus only. But there is a bear hug test. That is for your subscapularis. Bear hug test is for subscapularis. But not very sure about this beer can. Maybe boys like you had changed it to beer can instead of empty can. Okay. So that is about the test. Okay. And now there are a few more tests. So these are up to the, the sports injury, what I told you, the knee and the shoulder exclusively. Now let us read about some more important tests which we regularly see in the OPDs, like the Thomas test, the Thompson test. So Thomas test is very, very important. It is asked in the exam. So Thomas test is identifying the fixed flexion deformity of the hip. So what happens is whenever there is a hip problem, like, in TB hip or osteoarthritis or vascular necrosis, the hip goes into flexion deformity, right? So whenever it goes into flexion deformity, it is compensated by the lumbar spine because the patient has to walk. What is flexion deformity? That means hip is going and sitting in flexion. Do you think you can walk when the hip goes into flexion? We can't walk, right? So now what comes to your rescue is your spine. The spine comes and tell you, instead of you bending, I will bend more. Already I'm bending, lordosis, right? So now what do you do? Instead of hip you bending, I will bend more. That is, there is an exaggeration of the lumbar lordosis, right? So whenever there is an exaggeration of lumbar lordosis, the hip becomes straight. So to identify how much is the hip flexing, we are taking up this test which is called as the Thomas test. So the steps of the Thomas test also been asked in the INSET exam. So first what you do is you put the patient in supine position, right? And then what you do is you flex the opposite limb, that is your normal limb. You flex the normal limb. Once you flex the normal limb, the spine will think, okay, now some hip is flexing because both hips are friends. They are connected by pelvis, right? So one hip is flexing, so let me relax. Now, once you're flexing one hip, the spine will relax. But now what happens, because this hip, which is abnormal, hip cannot relax because there is some problem in it. Now, this goes into flexion. And now you have to identify with the help of goniometer. With the help of goniometer, that means there is a this goniometer is something like this. There is a scale like this, and then you have the angles also on it. So now what you do on this scale, you put over the femur, one limb like this it will be. So this is the goniometer. One limb on the femur and the second limb on the couch. So one will be touching the couch, one will be along the line of the femur. So now you measure the angle. So this angle is nothing but your fixed flexion deformity. That is your FFD. Understood? So now what happens is, because there is a problem in the hip joint. So let us assume that there is a problem in the right hip. Right hip. Now what are the steps you do? First step, what you do? Put the patient in supine position. Now what you do? Flex the left hip. You will flex the left hip. And then third, because you're flexing one hip, the spine will get relaxed. But the right hip, which is already damaged because of some pathology, cannot relax, right? So now this hip goes into flexion. Now what you do, you measure it with the goniometer. Goniometer is something like the protractor with the scale attached, so that you can move these two limbs. One you can put like this also in the 90 degrees. And now it will, this goniometer will show that it is the 90 degrees. So the angles between the two you can measure with the help of this goniometer. So once one limb, this is called one limb, this is called the second limb. The first limb you will put it along the axis of the femur. And the second is along the couch. So that is couch or bed where the patient is sleeping. So this angle between the couch, so the couch will always be straight like this, right? And now whenever the femur angle is like this, something like this or like this, you will measure the angle. So that angle is called your FFD, that is fixed flexion deformity of the hip. You understood? Can somebody please tell yes if you understood? Okay, Raj, thank you. Next is Thompson test. What is Thompson test? So Thomas test is for FFD. What is Thompson test? Thompson test is for tendo-Achilles. So if you remember, the tendo-Achilles is formed by the gastrocnemius and the soleus together. They get inserted into the calcaneal tuberosity, right? So this is the basic chunk of the sole. So whenever there is a tear in this tendo-Achilles, now what you do? You put the patient in the prone position and you squeeze the both the muscles. You squeeze the soleus and the gastrocnemius. So on squeezing, if there is a flexion, right? If there is which flexion, dorsal or plantar? So plantar flexion. So if there is a plantar flexion, then the tendo-Achilles is intact. If the plantar flexion is absent, then that is the Thompson test positive. Remember, the Thomas test is for FFD. The Thompson test is for your tendo-Achilles. Then what is one more T? The telescopy test. The telescopy is for your hip dislocation. So whenever the head is not sitting into the acetabulum, the head should always sit into the acetabulum. Now this head is not sitting into the acetabulum, right? And now what you do is, whenever you're moving the femur shaft, whenever you're moving, you can also feel that there is some movement in the head. So this movement of the head is called as the telescopy test. So this is positive in case of your hip dislocation, in case of your DDH especially. So you can feel the telescopy, right? And what is Dugas test? So this is again going back to your shoulder instability. So in case of shoulder instability, whenever a patient comes with your anterior dislocation of the shoulder, and what is the first test you do to rule out the anterior dislocation? It is not the X-ray. Clinically, what you ask the patient is, so if there is a right side anterior dislocation of the shoulder, what you have to ask the patient is, ask the patient to touch the opposite shoulder. So once if the patient is able to touch the opposite shoulder, you can rule out the anterior dislocation, right? So that is your Dugas test, touching the opposite shoulder. It is mainly seen in case of your shoulder dislocation. So Dugas test is for your shoulder dislocation, right? And next, what is Job's apprehension test? This is also similarly, because abduction and external rotation will cause your anterior dislocation, right? So this, yeah, Perth is also, you can see telescoping, right? Perth is also, yeah, you can sometimes appreciate in case of Perth is also, right? But the problem in Perth is the head itself cannot be, in later ends, the head itself cannot be felt there. Here the telescopy is mainly the movement of the head where you can feel, right? So that is it. Your drug of choice. Your drug of choice. The Perthes is a Perthes is where there is an avascular necrosis of the head. And what I'm trying to tell you is here the head is actually, you have to palpate the head and then you will try to move. And when you can see there is a movement of the head outside the acetabulum, that is called as your telescopy test. So what is Job's apprehension test? So Job's apprehension test is again for your anterior stability. Job's apprehension test is for anterior stability. So Job's, this telescopy, remember it is mainly for DDH, right, rather than for Perthes. Perthes also sometimes where there is a head which you can feel, there probably you can see in the later stages. What is SLRT? SLRT is straight leg raising test. So where do you see the straight leg raising test? So straight leg raising test is for two conditions. So this is of two types. One is your active straight raising test. The second one is your passive straight raising test. So what is active and passive? I hope you all know what is active and passive. Active is done by the patient himself. Passive is done by the surgeon. So in case of your active, if the patient is able to do, you can rule out your hip fractures, right? So when a patient comes with IC fracture, IT fracture, when he is able to do this SLRT actively, so you can rule out that if a patient is able to lift the straight leg, directly without any help, that means there is no hip fracture, because everything is intact, the head, the neck, and the femur is intact, hence is able to lift it up actively, right? If is not able to lift it up actively, then you have to suspect for any hip fracture. So the straight leg raising test, active, is suspicious, or it can be useful for assessing your hip fractures. When it comes to passive leg straight raising test, it is mainly to evaluate your sciatica. That means there is a sciatic nerve which is present on the posterior aspect, and now passively if you are lifting your limb up, passively if the surgeon is lifting the limb up, and now the patient complains about the pain, because whenever you passively lift or extend the knee, straight leg means you are lifting the knee on stretch, right? So when the knee is not flexing, you're extending the knee and lifting it up, you can see the tightness on the posterior aspect. So this tightness will result in stretching of the sciatic nerve, hence the patient will have pain, which can be used as a tool of diagnosis in lumbar canal stenosis or your prolapsed intervertebral disc disease. So straight leg raising test is for identifying your disc disease or your lumbar canal stenosis. The symptom is usually the sciatica, right? So there is a stretching of the sciatic nerve on the posterior aspect. Medic man, Pakistani student in Pak Medical College. Okay, welcome. Now coming to the Schober's test. So what is Schober's test? Schober's test is mainly for ankylosing spondylitis. You have to remember this. What is ankylosing spondylitis? So in ankylosing spondylitis, what happens is there will be the limitation of flexion. And this Schober's test is usually used for identifying this flexion limitation, right? So this flexion limitation is identified by this Schober's test. Oh, thank you so much, Medic Man, for reading. Hope you find it useful. Thank you. So Schober's test is that. So it is mainly used for ankylosing spondylitis, and this ankylosing spondylitis is mainly for, as I've told you, this is which causes the, what is this ankylosing spondylitis? It's a fusion of entire spine, right? So whenever the entire spine is fused, you can't flex. So this limitation of the flexion is identified by the Schober's test. So how do you identify it? First, you will ask the patient to stand straight, and then you will identify a point on the posterior aspect. So for example, dimple of Venus. As you all know, if you stand straight, you can see some depression over the sacral area. That is called the dimple of Venus. So you will identify that area, and from that area, you will mark or you will measure a 15 centimeters area. So from the show bus, that is dimple of Venus, you will measure some 15 centimeters, right? And now you ask the patient to bend. So on bending, if there is an increase in this particular area, then there is a flexion. If there is no increase in this particular whatever we have marked, no, that area is not increased, that means there is no flexion. So that is your show bus test. So forward bending is your show bus test. Can you tell me one more test where you do this again, the forward bending only you do and identify the condition? Forward bending, limited flexion is your show bus test. And one more forward bending test. Come on, Raj and Pratyusha, Sakshi. Yes, very good. It is the Adams forward bending test. So what is for? Yes, this scoliosis. Very good. The scoliosis, your drug of choice. What is your name, drug of choice? Yeah, scoliosis. So now you will identify what is the difference between your pathological scoliosis and functional or structural, right? So it could be structural scoliosis or postural, right? Structural or pathological or postural scoliosis. Postural scoliosis means because of some problem in other area, the spine is showing this scoliosis. Pathological or structural scoliosis is there is direct defect in the scoliosis itself. So Adams forward bending test. So that is Adams forward bending test, and this show bus test is for your ankylosing spondylitis. Very good. Now, what is Faber's test? Faber's is flexion, abduction, and external rotation. So simply remember this as figure of 4. So if you sit straight and you do this, putting your usually boys try to sit like this, folding, putting this feet on their opposite knee. This is called as the figure of 4 position. So what you do, you flex, you abduct, and you external rotate. So that is your Faber's test. And why do we do this Faber's test? We do this for identifying any pathology in the sacroiliac joint. Sacroiliac joint. So whenever a patient comes with pain in the back area, 2 important tests you have to do. So one is the SLRT, the straight leg raising test. So usually the pathology will be probably, it could be a disc disease, it could be a stenosis, or it could be a pathology in the sacroiliac joint. So these 3 areas you have to check. So first thing what you do, you ask the patient to bend forward on standing. So on bend forward, if he is able to flex, extend and everything, then his movements are fine, right? And then what you do, you ask the patient to sleep on the couch, that is supine position. On the supine position, you will do the active SLRT and the passive SLRT. So all this is done, then you do the Faber's test. So what you do, you try the patient or tell the patient to put his heel onto the opposite knee. So whenever he's trying to do this, if he find any pain on the posterior aspect, that means there is a pathology which is involving the sacroiliac joints. So these are the various tests how you identify a patient with the back pain, right? So this can be used for you clinically also, clinical assessment questions. If they put clinical based questions also, you can answer, right? So these are the various tests which we usually perform in the OPD also. Fine. Okay, Naveen. Okay, now we are done with the test and all. This is something which is, easy to remember. So what is student's elbow? Student's elbow is, this is a type of bursa. So if you see, there are various bursa in the body at various areas. So what actually is this bursa? So bursa is nothing but a structure which is present to decrease the friction or the movement. Whenever there is a the tendon is overlying over that bursa, and it reduces the friction between the movement of the tendon or any ligament like that. So what is a student elbow? Bursitis. Yeah. Student's elbow is olecranon bursitis. Yes, olecranon bursitis is student's elbow like this. And if you continuously sit, there is this olecranon, the bony structure, and there it will result in inflammation. There will be swelling and pain, and this is called as student's elbow. What is housemaid's knee? Housemaid's knee. Prepatellar bursitis. It is prepatellar bursitis, housemaid's knee. That is, usually the maids, they will clean, or they will mop with the wet cloth whenever they're trying to mop the floor with the wet cloth. Olden days, they used to knee, or they used to kneel down on the floor, and then they used to do this work. On kneeling down, there will be a patella, the prepatellar area. It will result in a prepatellar bursitis. What is nursemaid's elbow or pulled elbow? So if you see, there is a radial head. The radial head coming out of the annular ligament. Yes, head of radius dislocation. So this is not exactly dislocation, because dislocation is something which is related to the joint, right? So this is just the ligament which is surrounding the radial head. No, the radial head comes out of it. And this is particularly, it is given as a clinical case where usually you see this. Usually we see this in case of your children. In case of children, we see this nursemaid's elbow. What happens is, they try to completely extend their limbs and they try to rotate the child. It is a very typical scenario, you know. We play with the children, we try to lift them up and we try them to rotate like that. And whenever you do that, the radius head suddenly pops out of this annular ligament. And now the patient cries with severe pain suddenly, and they will bring to you that, probably if you are an orthopedic, you know, practicing surgeon. And what you have to do, and this is a very, very easy way to reduce it. What you have to do is just flex the elbow and then supinate. So once you just flex the elbow and then you try to supinate, the radial head will go again and sit inside the annular ligament, and this child suddenly stops crying. So this is very gratifying and very satisfying procedure we can do in the OPD, because as immediately as you do this maneuver, the absolutely the child stops crying and starts laughing just like that, as a magic. So this is the very important you know, pediatric surgeons, what they experience, that is the nursemaid's elbow or the pulled elbow, right? Then what is the clergyman's knee? The clergyman's knee is infrapatellar bursitis. So let's make it a little faster. We are still in table 6. Infrapatellar bursitis is your clergyman's knee. Then what is your tailor's knee? What is your tailor's knee? Tailor's knee is lateral malleoli. So all those important bony parts, you have to remember. The tailor, you know, continuously will do this movement. On the lateral side, you know, there will be pain, or the bursa will keep developing. That is on the lateral malleoli. Bursitis is your tailor's knee. Then what is weaver's bottom? Weaver's bottom is continuous sitting, the ischial tuberosity bursitis. The ischial tuberosity is involved. That is your ischial tuberosity bursitis is weaver's bottom. And what is bunion? Bunion is first metacarpophalangeal joint. Not metacarpo, it is metatarso. Down, foot. First MTP. Yeah, first MTP is involved. Yeah, first toe or first MTP is bunion. What is bunionette? What is bunionette? This is homework for you. Identify what is bunionette. What is tennis elbow? Very, very easy. Again, tennis elbow is medial epicondylitis. Sorry. Tennis elbow is lateral epicondylitis. What is lateral epicondylitis? So this lateral area, lateral aspect of the area, patient comes with severe pain, and which tendon is involved? Extensor carpi radialis brevis. Please remember this. Sachin Tendulkar wala. Yeah, Sachin Tendulkar, though is a cricket player, he has suffered with tennis elbow. Very good. Golfer's elbow is opposite. That is medial epicondylitis. Right, lateral epicondyle is an origin of Common origin, CEO. Common extensor origin is your lateral epicondyle. Medial epicondyle is CFO. Common flexor origin. Very good. Bayonet is fifth metacarpophalangeal joint. Fifth MCP. Fifth MTP. Just you have to remember bunion is first and bunionate is fifth MTP. Right? Next, 𝐷-𝐶𝐝 stenosynovitis. What is 𝐷-𝐶𝐝 stenosynovitis? First compartment, APL, EPB. So, if you remember, there are 6 compartments. Yeah, bunionate is fifth MTP. So, if you remember, in the hand, we have 6 compartments where we are placing the extensor tendons, right? So, in that, the first compartment is occupied with this APL and EPB, abductor pollicis longus, extensor pollicis brevis. So, when these two tendons get inflamed, that is tenosynovitis. Itis is inflammation. Tenosynovium is the layer or the sheath of the tendon. So this tendon is covered by a synovial sheath which is called as tenosynovium. So whenever there is an inflammation of this tenosynovium, it will result in tenosynovitis. So these two are the tendons where the tendon sheaths are getting inflamed. So this is called as the 𝐷-𝐶𝐝 stenosynovitis. And what is the test which we use for identifying the 𝐷-𝐶𝐝 stenosynovitis? Faster, faster. It is the, yes, very good, Finkelstein test. And what is the test for tennis elbow? Faster. Pratyusha has left or what? She's feeling sleepy probably. Tennis elbow? Faster. Tennis elbow is Cousins test. 𝐷-𝐶𝐝 is stenosynovitis is Finkelstein test. What you have to remember is APL and EPB, right? And then, no ma'am, for what? Tennis elbow is Cousins test, right? Okay, reverse Cousins test is for your golfer's elbow. So this is for reverse Cousins test. So remember that tennis elbow, the Cousins test, the golfer's elbow is reverse Cousins test, and 𝐷-𝐶𝐝 stenosynovitis is Finkelstein's test, right? So that is the table 6. Going to table 7. Can't recall Cousins. Okay, no problem. Cousins test. Now we will never forget. So Cousins test is for your tennis elbow. Very good. Now there are certain angles which they might ask you in the exam, and I have put all the angles here. So once you read this one particular table, no, you can identify all the angles. Yes, very good. The 𝐼𝐀's angle, CTEV. Q angle, patellar alignment. Q angle is to identify the patellar alignment, right? Remember, Q angle is nothing but your quadriceps angle. So quadriceps is related to your patellar alignment. Very good. 𝐼𝐻's angle is CTEV. Here the angle exactly becomes 0, which is called as parallelism, and this angle, 𝐼𝐻's angle, is between your talus and your calcaneum. Okay, the talus and the calcaneum, the angle between talus and the calcaneum, it becomes 0 degrees. This is called as parallelism, which is seen in CTEP. Q angle is quadriceps angle, which is useful for knowing the patellar alignment or patellar dislocation. So what is Gisens and Bowler's angle? These two are useful in case of your calcaneum fractures. So calcaneum fractures, there are 2 important angles. We have already dealt with the classifications. So the CTE classification is your Sanders classification. Your X-ray classification is your Essex-Lopresti classification, right? And the angles in calcaneum are Gisens angles and Bowler's angles, right? Then what is Bowman's angles? Bowman's angle is for your elbow fractures. So identifying the elbow fractures, especially in case of children, you have to take this Bowman's angle. So what is a Bowman's angle? So direct your, if this is your humerus, and this is your capitulum. So there is a line which is drawn along the humerus and the capitulum. This is almost near to some 70 degrees like that, and this is always in comparison. What is scoliosis? Okay, Cobb's, okay, fine. So 70 degrees. So you have to always compare to the opposite side. Compared to the opposite side, right? So this Bowman's angle is seen in case of your elbow fractures. Then Cobb's angle, yes, Cobb's angle in case of scoliosis. Scoliosis, Cobb's angle normally 10 degrees, and depending upon the degree, that depending upon this angle, you will treat the patient. So this patient can be 20, 40, more than 40, right? So if it is a 20 degree scoliosis, you go for just observation. If it 20 to 40 range, you go for bracing. And if it is more than 40, you go for surgery. That is the importance of Cobb's angle in case of, right? So what is carrying angle? Carrying angle is a normal angle which is between your arm and the forearm, right? Arm and the forearm. Normal 11 degrees in males and 14 degrees in females. So you have to remember that female, the angle is more, right? So it is a carrying angle between, this is the angle which is present in arms and forearm. So usually we have a slight valgus, right? So what is alpha and beta? So this is in case of your DDH. DDH is developmental dysplasia of the hip, and usually these angles are seen in ultrasound. Ultrasonography of the hip is done in neonates because the head is not actually formed, right? So no x-rays, nothing. First you will do DDH. In case of DDH, what is the diagnosis? So first is clinical diagnosis, right? So you do two important tests. What are the two important tests? Barlow and Otterloni. Otterloni and Barlow are the two important tests which you do. And what is the angles which you measure? The alpha angle and the beta angle. So usually the alpha is more than 60 degrees. More than 60 degrees normally. And beta is less than 55 degrees. If it is opposite to it, then you have to think of DDH, right? Normal is more than 60, beta is less than 55. Reverse of this is DDH. And what is neck shaft angle? Neck shaft angle, the angle between the neck and the shaft of the proximal femur. It is somewhere about 125 to 135 degrees. Any increase and decrease will result in what is called as varus and valgus, right? Right, these are the various angles which you have to remember. The Keith's angle in case of CTEV, just remember the conditions, which is very, very important, right? CTEV is the condition, so Keith's angle is seen in CTEV. Ghissens and Bowler's is seen in calcaneum fractures. Q angle is seen in patellar dislocations or patellar malalignments. Bowman's in case of your elbow. Cobb's in case of your scoliosis. Carrying angle and neck shaft angle are the normal angles, but these are important whenever you have to assess or treat the deformity, such as varus deformity in elbow or valgus deformity in elbow. Similarly, varus deformity or valgus deformity in case of your femur, right? And then alpha and beta angles are seen in case of your DDH. Yeah, coxa vara and coxa valgus are the terms which are given for your neck shaft angles, right? So this varus is usually seen in case of skiffy, right? So those are the hip areas where you see. And in case of elbow, if you see varus, the gunstock deformity, and in case supracondylar fractures, so gunstock deformity, the carrying angle is further decreased, right? So that is the importance of knowing these angles. Now, which angle is what? So this is your Bowler's. This is your Ghissens, right? So identify the structure, the topmost structure on the posterior aspect, and this line is drawn along the, this is called the strut, right? So one on the posterior aspect, on the anterior aspect you draw a line, and one more point is over the calcaneal tuberosity, and now you draw a straight line. So this is the Bowler, and this is along the struts, the anterior and the posterior strut. This is your Ghissens. So I've given you the picture directly. So Bowler's is almost 20 to 40 degrees, and it will decrease in case of your calcaneum fracture. 𝐒𝐬 is somewhere around 140. It will increase in case of a calcaneum, right? 135, 130 to 140 somewhere around. So these are the various important angles. Now these are the so so now we excuse me for that. So now we have finished the angles. So these are certain names which are given to osteonecrosis. So osteonecrosis. Osteonecrosis, whenever this osteonecrosis occurs in case of femoral head. Femoral head. This is called as the Perthes. Pratyusha is back again. So femoral head, this osteonecrosis. What is osteonecrosis? So there will be a loss of blood supply to that particular part. So whenever there is a loss of blood supply to that particular part, that particular bone will die. So this is called as necrosis. So this is the bone necrosis, hence it is called as osteonecrosis. So whenever you see this particular osteonecrosis in case of femoral head, this is called as Perthes disease, right? So femoral head osteonecrosis is called Perthes disease. Similarly, Kienbock is seen in lunate. So how do you remember Kienbock? Remember lock and key. Key, lock. So lunate. Lock, lunate. Kienbock is key for it. Kienbock is lunate. Next, what is this? Kienlun. Okay, fine. Next is Osgood-Schlatters disease. Osgood-Schlatters disease is again a necrosis, a type of necrosis, and this is mainly not the epiphysis, this is the apophysis, that is tibial tuberosity. Tibial tuberosity, apophysis. What is apophysis? So epiphysis is one which will give you length. Apophysis is the part which give you increase in the circumference. So this particular apophysis, whenever it is damaged, it will result in Osgood-Schlatters disease. It is a self-resolving disease usually seen in young people, right? That is Osgood-Schlatters disease. Knee. Next, Sever's disease. Sever's disease is seen in calcaneum. So usually we have this a tablet which is called as Shelcal. Shelcal is usually prescribed for calcium supplements, right? So that is how I remember calcium Sever's. So Shelcal, right? Sever's is Shelcal. Kienbock is lock and key, what I told you. Next is Kohler's. Kohler's is navicular. So Kohler, I only remember Virat Kohli by that. And here we have VIV, Virat and Kohli. So that is Navi and Kohler. That is navicular is Kohler's, right? Next, Freiberg's. Freiberg's is metatarsal head. And next, Panner's. Panner's is, how do you remember? It is capitulum. So remember PAN card. PAN card. So usually we are now very much interested in these Aadhaar cards and PAN cards, right? So Panner's is capitulum, that is PAN card. And what about Eisley's? Eisley's is also metatarsal. Metatarsal, but this is base. So Freiberg and Eisley, I have wrote metatarsal and metatarsal, right? So Freiberg's is second metatarsal, Eisley is fifth metatarsal base. So how did I remember is, if you remember Meta is a company which is related to both Facebook and Instagram, right? We are very, very familiar in those two social media, Facebook and Instagram. So remember Freiberg and Eisley is both goes to Meta. Because Facebook was first in our times, no? So that is second. And Eisley has come next. That is Insta is next to it. So fifth. Remember like that. You know, Freiberg and Eisley is for metatarsal head and base. Okay, you just don't worry about it. Just remember Freiberg and Eisley, that is both related to Meta. So Meta is a company, right? Which is you know head for this both Facebook and Instagram. Panner's is capitulum. PAN card. You know, PAN card is as capitulum. Next, Blount's. Blount's is tibia. Tibia vara, bilateral tibia vara is Blount's disease, right? Then what is Scheuermann? Scheuermann is again ring epiphysis of the vertebra. Ring epiphysis of the vertebrae, right? Then what is Hagland? Hagland is calcaneum. It is again their Hagland deformity. So there is one thing which you have to remember is Hagland deformity. Then what is Precious? Precious Panners. So in Precious pan card, we already know that Panners is capitulum. Precious we have S, and that is your scaphoid. Head. What is head? Pratyusha, head for what? Freeberg, huh? Okay. So Precious is scaphoid. Hope you all understood this. I have come up with something to remember. If you like it, you go ahead. Otherwise, you put up your own mnemonics and remember. But somehow remember and answer in the exam. That is the vital important, vital thing to do. So Perthes, femoral head, Kienbock's lock and key, lunate, Osgood's lateralis, tibial tuberosity, CBS is shell cal. I've told you. Polus is navicular. Virat Kohli, you have to remember. Freeberg and Iceland both belongs to meta, that is second and fifth, right? Metatarsals. Then Panners is, remember it as pan card. Panners is capitulum. Blount's disease is for tibia. And then Scheuermann's is ring epiphysis of the vertebra. And Scheuermann's also, remember, it is one of the reason for kyphosis, right? And then Hagland deformity is usually seen in calcaneum. And Precious is for scaphoid. That completes the table 8. Now, these two tables are usually very easy, but they are usually asked in the exam. Very important, Not going to sleep. Let us try to write this. Ma'am, is SLRT done for malingering? Yeah, you can. See, SLRT is subjective. Patient has to wince with pain. Then only we can tell that whether it is, positive or not. Active SLRT and passive SLRT both are, patient has to do it. On the passive SLRT is you do it. The surgeon will try to extend the limb, but on extension of the limb, on stretching of the posterior aspect, on stretching of the sciatic nerve, at one particular time, the patient will complain of pain or wince with pain, and that angle you have to take, and then you have to see whether it is matching to your diagnosis or not, right? So it can, so patient, if he is, able to understand what we are doing, then they can malinger. So this is the fracture and the vessel injury, and next table is fracture and the nerve injury. So shoulder dislocation anteriorly. Very good. It is the axillary nerve. Axillary vessel. Axillary vessel. So whenever there's a shoulder dislocation anteriorly, the vessel which can be injured is your axillary vessel. Axillary artery, not vessel, axillary artery. And then hip dislocation is your femoral artery. And I have specifically mentioned it as the anterior, right? Anterior. And what is knee dislocation? Popliteal. Very, very easy, right? Popliteal. And proximal humerus, again, there is a damage to your axillary artery. Supracondylar, brachial artery, right? Supracondylar, very, very, very important in this whole table. If you remember this, I am very, very happy. Then pelvic fractures, if you remember, I've already told you when I was teaching you open book fractures. There are two important arteries which you are concerned, the sacral iliac artery and the internal iliac artery. So these two are the arteries, the internal iliac and the sacral. Next comes the fracture femur. Femur also, it is femoral artery. Probably they're talking about the proximal femur. Then supracondylar femur. Supracondylar, once you're going down towards the knee, always remember the popliteal artery is at the wrist. Ankle posterior tibial artery. Posterior tibial artery. So this is very, very important table. And I know you can easily remember because it is something related to anatomy also. You can imagine the ankle is related to posterior tibial artery. Supracondylar femur is something related to knee, right? On the posterior aspect, so popliteal artery like that. So what is most important is the supracondylar humerus, that is the brachial artery is very, very important. Okay. Coming to the next one, nerve. Nerve, again, shoulder dislocation, it is again your axillary nerve, right? Shoulder dislocation, it is again the axillary nerve. Not just tibia, yeah, posterior tibial artery rest. Next, proximal humerus, again, it is the axillary nerve. Humerus shaft, we have already dealt. What is Holstein-Lewis fracture? It is the radial nerve, right? And then supracondylar humerus, remember, through, right? So first is the anterior interosseous nerve, median nerve, radial nerve, ulnar nerve. AIN, median nerve, radial nerve, ulnar nerve, right? Supracondylar humerus, right? Then medial condylar humerus. So anything, whenever they talk something on the medial aspect of the elbow, it is always the ulnar nerve. So ulnar nerve is present, which is usually little, superficial only. That is the, on the medial aspect, you can actually feel the ulnar nerve. So whenever there is a medial condyle fracture, there will be a damage to the ulnar nerve. The Monteggia, we've already discussed, the posterior interosseous, and posterior dislocation of the hip, it is the sciatic nerve. Raj, why are you not answering the questions? Knee dislocation, popliteal nerve. Neck of fibula, this is again very, very important, which was asked again in the exam. Neck of the fibula, common peroneal nerve. Ankle injuries, posterior tibial. So now we are done with all the 10 tables, right? So these are all the important facts. I mean, like it could be asked as a one-liner. We have discussed some few important concepts. Now let us go to the image-based questions. So whenever I tell image-based questions, the first thing you have to read is about the tumors, splints, instruments, X-ray. So these are mainly asked image-based questions in case of ortho. And the first image is, yes, this is again an exam question. So exam question, what is this? The very good. It is the shepherd's crook deformity. Yeah. Fibrous dysplasia. And once you see this fibrous dysplasia, you have to think two things. Whether it is a single bone or multiple bone. Single bone, good. Multiple, think of a syndrome. What is the syndrome? 𝐒𝐄𝐝-Albright syndrome. What are the components of it? Precocious puberty plus 𝐒𝐄𝐝-Albright. Yeah, 𝐒𝐄𝐝-Albright syndrome, where you see there is a polyostotic fibrous dysplasia with the precocious puberty. In case of your females, usually seen in case of females with precocious puberty is called your 𝐒𝐄𝐝-Albright syndrome. Then what is your Musabroad syndrome? Musabroad is intramuscular myxomas. So intramuscular myxomas with your this shepherd crook deformity, whenever you see, it is called as the Musabroad syndrome, right? So this is about the fibrous dysplasia. Usually we see it single, but whenever we see multiple polyostotic fibrous dysplasia, whenever it is associated with precocious puberty, yeah, very good. Cephalid spots. So cephalid spots also is seen in this case. So whenever you see this capillate spots, that is hyperpigmented spots, it is called as your 𝐒𝐿 syndrome. So this is the this is the bone which is deformed. Why it is deformed? Because this is the bone is replaced with the fibrous. So hence the bone is able to withstand compression. It is going into deformity, and on the x-ray what you see is the ground glass appearance. You see what is called as the ground glass, right? So this is very, very important. This fibrous dysplasia, capillate spots, precocious puberty, which will result in the 𝐒𝐿 syndrome. And whenever it is intramuscular myxomas with your fibrous dysplasia, it is called as your Mazabrod's syndrome, right? Very, very important. The first important image, right? The second one, what is this? So it is the most common benign tumor-like condition, right? It is not directly a tumor. It is a tumor-like condition. It can be considered as an aberrations in case of your growth plate. So why I'm telling it as an aberrations in case of your growth plate? Because this is an extra growth, which is also called as exostosis, and multiple exostosis. Similarly, like your previous one, the fibrous dysplasia, if there are multiple exostosis, what is this condition called? Type the answer, and before that I will teach you what is a growth plate. So here if you see, this is the growth plate, and here why did I tell you this is an aberration of the growth plate? That means there is some error in the growth plate, and now this forms as an extra bone like this. So why are we considering this as extra bone? Because there are two things in it. There is a bone on it, and then there is a cartilage which is covering this bone. So this can be both. It could be a sessile one, or it could be a pedunculated. That means it could be like a sessile is directly on the bone. Pedunculated is with the stalk, right? So whenever there is a stalk, it is pedunculated, and this is a structure which is having two structures. One, there is a bone, and then this bone is covered by a cartilage. This cartilage is usually not seen on the x-ray. Hence, whatever osteochondroma you see in the x-ray, it is always small when compared to the real ones, right? So what is this extra multiple exostosis called? Brown, sir. Brownies. So this extra multiple exostosis is called as diaphyseal achalasia. Diaphyseal achalasia. So in the recent FMGE, what they have written just 1 week before you, there is a talus which was given, and then this extra growth was given on the talus, right? So not to be confused with that, usually this extra growth can be seen on any part of the bone. If you see this exostosis on one particular bone, you have to always examine clinically for the other bones also, just to find out if there is a diaphyseal achalasia, the underlying condition where multiple exostosis is, right? So these are the few important points regarding your osteochondroma, where you see the bone covered with the cartilage, right? And it is usually in relation with the growth plate. So usually what happens, it stops after skeletal maturity. So this growth of the bone stops after skeletal maturity. You can reassure the patient that this is not going to increase in size after skeletal maturity. But there are certain conditions which the patient has to be careful. Whenever there is an increase in pain or increase in size suddenly, or if there is a bursitis, that means this particular growth is touching the bursa, or if that it is irritating the nerve, then you go for X. What is the most important condition which we go for excision? What is the most important condition in all? Increase in pain, increase in size, bursitis, or irritating the nerve. What would be the most common reason for excision? Yeah. You have to always keep checking for the size of the cartilage. If there is a sudden increase in the size of the cartilage, that means it is turning into malignancy. That is fibrosarcoma, which can occur here. Okay, what is the most common condition for excision? Reason, probably. Cosmetic. No, not malignancy. Malignancy is very rare in osteochondroma. The most common is not pain also. Usually we remove it for cosmetic purpose. Even though we tell the patient that this is not going to increase or it is not going to cause you any harm, but because of the cosmetic reasons, patient get it removed. Yes, cosmetic. Very good, Pratyusha. I know you're going to take ortho only. So this pain and increase in size are also one of the most important reasons where we can go for excision, right? So what is the instrument which we use for excision? Instrument. So instrument what we use is, okay, good. Ops and gynae, very interesting, very good. So now let me know what is the instrument we are going to use to remove this osteochondroma. The most important instrument which we use in removing this osteochondroma. I'm waiting. Now, please, everybody concentrate on the ortho now. Shift your concentration from Pratyusha to me. So the important instrument which is used for removing this, it is osteotome. It is osteotome. Osteotome is mainly important in removing this, right? So that is the instrument, right? And now what is this? Still we're in image 3. We have to go more. 7 images are waiting for us. What is this image? Yes, very good. This is a glass holding cast. Glass bowler's cast. Okay, so this is a glass holding cast and this is used for the scaphoid fractures. And scaphoid fractures are one of the most important. Why? Because they are usually missed. And where do you examine for the scaphoid fracture? Where you examine? Which area? Which anatomical area you examine? Anatomical area, which one? You look for anatomical. Yeah, very good. Anatomical snuff box. So that is the area where you have to look for the scaphoid fractures. And what are the important views which we take for scaphoid? One is your AP wrist view, and then you take the lateral, and the third one is, most important one is your view, X-ray view. X-ray, you take AP view, you take the lateral view, and then which view? Yes, you take the oblique view. Very good. You take the oblique view. When you take the oblique view, you can identify the fracture. And once you see the fracture, you have to go for glass holding cast. And if you clearly see, what is the difference between the Colles cast and your scaphoid cast? So Colles cast and the scaphoid cast. What is the difference? One thing you note, the thumb. In Colles cast, the thumb will be left free. There is no cast which is applied to the thumb. But in case of scaphoid fracture, you extend this cast which includes the thumb. right? So this is called a glass holding position. So this is the glass holding position, and we include the thumb. In case of Coley's cast, you see this thumb is free. So that is the basic difference which you have to look, whether you have to identify it as a Coley's cast or a scaphoid cast. And one more thing what you have to remember, the scaphoid is one of the most important carpal bone which is usually missed, and you have to go for three views, AP lateral and the oblique view, and you have to examine for your you have to examine for your anatomical snuff box. So anatomical snuff box is one buzzword which you have to remember, and the second one is oblique view, which you have to remember because the other two you already know, and thumb is included in cast. And the next one is about the avascular necrosis. Why the scaphoid is prone for avascular necrosis? What are the other two areas which are important for us regarding the avascular necrosis? One is scaphoid, the second one and the third one. Can somebody please tell me fast? What are the other two bones which are mostly prone for avascular necrosis? One is scaphoid, the second one and the third one. Faster. Scaphoid is already written here. Okay, femoral neck. Very good. Yes, the talus. No, these three. So the scaphoid, the femoral neck and the talus. So these three are the areas which are prone for avascular necrosis because of the peculiar blood supply, that is the retrograde blood supply. So in the case of your scaphoid, it is from distal to the proximal. So here what happens, the waist, that is the center part of the scaphoid, is at risk, and femoral neck, the head is at risk, and in case of talus, the neck is at risk. So these are the areas which goes into avascular necrosis. For the scaphoid, it is the waist which goes into avascular necrosis. For femoral neck fractures, the head is one which goes into the avascular necrosis, right? And the talus fracture, the neck is the one which goes into avascular necrosis, right? So these are the three important areas which you remember, and these three important areas are also the sites of which thing? The malunion or the non-union. These are the sites for avascular necrosis prone to non-union, malunion, delayed union. Yes, these are the sites which are also prone for non-union. Very good. So there is a non-union, there is a malunion, there is a delayed union, right? So these are the sites again which are examples for your non-union. What are the, which of the following is known for non-union? A scaphoid, B femoral neck, talus, all the above. The answer is all the above, right? And yeah, supracondylar fracture humerus is going for malunion. Malunion, what is the meaning of malunion? Non-union means there is no union because the fracture is not uniting at all. What is malunion? There is a union, but there is malalignment of the fracture. So instead of attaching, instead of using normally, it malunites. There is a change in the direction of the union. Hence, it results in varus or valgus depending upon the fracture. So that is malunion and non-union, right? Yes, Coley's myths are all malunion. So they will result in deformities. So what are the malunion deformities? So we know one is your dinner fork deformity. Then is your garden spade deformity. So dinner fork is for Coley's. Garden spade is for Smith, right? And then we have your gunstock deformity. What is gunstock deformity for your cubitus? Yeah, good. Good. Very good. So these are the malunions where the distal radius, the IT, distal radius are the areas for malunions. The intertrochanteric, IC is for non-union, intercapsular is for non-union, intertrochanteric is your malunion, right? So these are the areas of malunion. Lateral condylar, supracondylar is all, no, supracondylar is again malunion. Lateral condylar is non-union. Supracondylar is for malunion. Lateral condylar. So one more side you can add, the lateral condyle humerus is for, because this lateral condyle humerus is intra-articular. So something which is intra-articular is always for non-union, right? Good, understood? Then what is this? Implants. So one implant what we have dealt is osteotome. We have told that is used for excision. Then what is this? Faster, faster, faster. Yes, it is bone nibbler. Yeah, bone nibbler. This is bone nibbler. So when do we use it? Usually when we see this is the fracture. So what happens is these are small fragments which are present attached to it, right? Like this. So we try to trim the bones. That is the bone nibblers. Bone nibbler for disarticulation. Okay, not for disarticulation, it is for nibbling the bone. That means you just trim the bone parts, bone ends, the sharp ends like this. You try to nibble. So you will try to remove the bone from the bone. That is, it should be strong, right? So it is called the bone nibbler, right? If it is a bone cutter, these ends will be sharp like this, right? It is like your nut cutter, like that it will be, bone nibbler. So what are the instruments which you have to revise? So one is osteotome, usually they ask bone nibbler, and third one they will ask you about the mallet, which is very, very important. Then they will show you the K wires, which is again important, and then they might ask you about the implants, right? So these are the various instruments which you again have to revise. So for now, this is a bone nibbler, right? This is your bone nibbler. Again, there will be heavy duty nibblers also. I mean, like very huge nibblers also will be there. Don't get confused. So this is the bone nibbler. What is this? It is a brace only. Now, what type of brace is this? Yes, yes, this is a Boston brace. So again, you have to remember image-based questions. Again, they will ask you about the splints and braces. So splints, what we have learned is one is your cock-up splint. So where do you use the cock-up splint? Faster. It is used for radial nerve, right? And then we have your knuckle bender splint, right? You have your knuckle bender splint, right? And then we have your aeroplane splint. Then we have your Thomas splint. First answer for this knuckle bender, aeroplane. Yeah, knuckle bender is for your ulnar nerve. Very good. Aeroplane splint is for your, yes, very good, brachial plexus. Thomas splint is for your, Thomas splint is for your femur fracture. Oh yeah, neck of the femur is not very useful. Shaft. Femur fracture is shaft. Then Bowler Brown splint, BB splint. Yeah, shaft, very good. BB splint. BB splint is again for your femur, probably your proximal femur. Okay, then Dennis Brown splint. Then Von Rosen splint. Faster, Dennis Brown splint and Von Rosen splint. These two are. BB splint is for proximal femur. Okay, Dennis Brown is for CTEV. Very good. Von Rosen splint is for your. Von Rosen splint is for Yeah, very good. DDH. Good. So these are the various splint, the cock-up splint, the knuckle bender, aeroplane, Thomas splint. Thomas splint is mainly used for shifting the patient, that is femur shaft fractures. Okay. Bowler Brown splint is the splint which is like this. It has one pulley and it has three segments like this, right? So this is the bowler splint, the bigger one, right? Thomas splint is something like this. This is your Thomas, right? So this Von Rosen splint, you already know that is used for DDH. Dennis Brown splint is for your CTEV. Now coming to the braces. So braces, first one we have understood there is a Boston brace. Then we have your Milwaukee brace. Then you have your Somai ash brace. Yeah, here the Boston and the Milwaukee are both for your folios. And one more thing you have to remember, the Taylor's brace is also for your scoliosis. The Boston, Milwaukee, and the Taylor's. These three is for your scoliosis. Then what is Philadelphia is a collar. Okay, we'll go to that next once we complete the Somai. The Somai is the occiput and the mandibular is included. So this is mainly used for cervical. Ash is also for thoracic, upper thoracic. It is called anterior spinal hyperextension. Taylor brace is used for scoliosis. No. See, Taylor's brace is mainly used for your tuberculosis. Taylor's brace is mainly used for your tuberculosis. So once they finish starting stages or somewhere, they can use this also for scoliosis, but mainly so Taylor's is for tuberculosis. Boston and Milwaukee is for your, I have written Taylor's here. Boston and Milwaukee is for scoliosis. Somai is for cervical. Any cervical problem is for this. And anterior hyperextension, ash brace is for thoracic. That is mainly your upper thoracic. And Taylor's is for your tuberculosis. So tuberculosis, mainly Taylor's brace is used for your tuberculosis. Right? So these are the various braces. Did we miss any brace in between? Then coming to the collars. So collar we have two. One is hard collar first, and then we have the soft collar. Then we have the Philadelphia collar. Then we have four-post collar. Right? So these are the collars. We have the hard collar, the soft one, the Philadelphia collar, and the four-post collar. Everything is for cervical only here. Nothing to remember more. So for the hard collar, this is mainly used for trauma cases. So trauma where there are cervical fractures, you use the hard collar. Similarly, the soft collar, what you use here, the soft collar is for cervical spondylosis. Cervical spondylosis. So Philadelphia is for a tracheostomy hole. And four-post collar is again for your occiput fracture. Yes, hard collar is for your trauma. Whenever there is a trauma, you encase the patient in the hard collar and then you shift. The soft collar is mainly used for cervical spondylosis. And see, once we stabilize the cervical spondylosis, we will not get any access of the neck area. But if you have to give airway to the patient, or if there is any other related injury to the lung, so for Philadelphia has come up with this answer where they give a hole in the anterior aspect of the collar where you can make a tracheostomy to be done even with the collar intact. So that is your Philadelphia collar for tracheostomy. And then your four-post collar, that is there are four posts which are present and it is used to stabilize the C1 and C2 with the occiput. Any fractures are present. So that is your four-post collar which is present, right? Which is used, the four-post collar. So these are about the various splints, various braces and the collars. And finally, the image. So now there is a trend where they're asking about the CT image, the MRI image. So this is an example of a CT image where you can see that there is a slight, there is this periosteal reaction and if you can see, this is which investigation I'm talking about. So on the right side, what is the investigation? Is this a CT scan or an MRI? This is X-ray, no doubt. Naveen, this is a CT or an MRI? This is a CT scan. This is a CT scan. What I'm showing on the on screen is the CT scan on my right side. This is a CT scan. So why did I tell it is a CT scan? Why not an MRI? So now I'm trying to read the cortex, the bone, right? Bone. And what you can see is, this is the bone. This area is the bone. There are no soft tissues which are seen here, right? You can see any muscles or something like that. So if it was an MRI, you will see all the muscles also. No muscles, the tendons, the soft tissues, everything will be present there. But here you see only the two bones. The one bone is your tibia, the second one is your fibula. So whenever you see two bones, it could be either a leg or your forearm, right? So in the leg we have two bones, again in the forearm we have two bones, the radius and the ulna, right? So here I've given you the leg x-ray. So the CT scan is corresponding to the leg, where it is showing one tibia and one fibula. So in the tibia, if you see, there is some reaction here, and here you can see some area which is called as the nidus. This is called as the nidus. So whenever you see this nidus in case of the CT scan, you have to always suspect osteoid osteoma. Osteoid osteoma. So what is this osteoid osteoma? Usually seen in case of children, right? And the nidus of less than 1 centimeter, and usually patient present with night pains relieved by giving NSAIDs. Why it is relieved by giving NSAIDs? Because this osteoid osteoma has a tendency to produce prostaglandins. So these prostaglandins are being suppressed by giving NSAIDs, because these are prostaglandins inhibitors, right? These NSAIDs are antiprostaglandins, right? So that is why the pain gets relieved, and this is also a therapeutic test for your osteoid osteoma. These are the important points which you have to remember. And on the x-ray you see nothing for osteoid osteoma except this periosteal reaction. This also sometimes we don't see. But what is the investigation of choice? I've told you on. Okay, if it is not responding to the pain, you can think about osteoblastoma. There is one more sister of this osteoid osteoma where similar things are present. See, the thing is, whenever it is subsiding with NSAIDs, that means it is osteoid osteoma. If it is not subsiding with the pain, it could be any other thing, right? It could be an injury, it could be some other thing which we are missing in it, right? It is not like if it is reducing with the pain, it is osteoid osteoma. If it is not reducing, it is this. Nothing like that. Only if it reduces with the pain, think about osteoid osteoma. If it is not reducing, then you have to explore other options. One more similar option is your osteoblastoma. It is similar, not exactly osteoblastoma. It is just similar to osteoid osteoma, where this also present with nidus. It also present in case of children. But what is the only difference? Osteoblastoma is the nidus is more than 2 centimeters, and usually the osteoblastoma is seen in case of vertebrae, and that too in the posterior elements. So there are certain peculiarities of each tumor, right? So for example, if somebody has to tell this is osteoma, then you have to be like the nidus has to be present on the CT scan, and it should on the X-ray, it shows the periosteal reaction, and the investigation of the choice will be CT scan, because in the starting class I've told you the bone is usually seen on the CT scan. Soft tissues usually we go for MRI, like the ligaments, the tendons, we go for MRI. Whenever you want to read about the bones, you go for scan. So if this is not responding for NSAIDs, if the pain is not reduced on NSAIDs, that means it could be anything else. That it could be infection, it could be an inflammation, it could be just some other thing which we need to explore more. But something which is related to osteoma is osteoblastoma, but the most common area of osteoblastoma is vertebrae, especially in the posterior elements. And one important thing is more than 2 centimeters. The nidus is more than 2 centimeters. Understood? That is about your osteoma. And then what is this? Yes, very good. This is called as the gunstock deformity. What is a gunstock deformity? So this is usually seen in supracondylar fracture humerus, right? And this is a condition of malunion. It is called as cubitus, right? And it is also called as a gunstock deformity. And what is actually a problem with this? Flexion will be limited by this. It will be more of hyperextension. Flexion will be limited. So the patient can't eat. The most important function of the hand is to eat, right? So the flexion increase in hyperextension. That is the problem. This is the deformity, right? And how do you treat it? Treat it with any correction of the bone is called osteotomy. And what is the osteotomy which you do? This is called as, the name given to it as the French osteotomy. The surgery for correction of cubitus varus is French osteotomy. Similarly, we have lateral condyle fracture, which results in non-union. And there is one more condition which you have to remember is your adi of pulse. This is seen in your lateral condyle fracture tumors. Right? Two important conditions. One is your supracondylar fracture humerus, where it is a result of malunion results in cubitus varus, and there will be limitation of flexion, and hence you go for treatment of this condition. That is your surgical treatment. That is your osteotomy. The name given to it is your French osteotomy. 3-point bone disrupted in lateral condyle. Yes, very good. There is a 3-point bony disruption. This is maintained. Right? So this condition, what I want to remember is your tardy ulnar palsy. That means patients presents with claw hand. So the patient comes with claw hand, that is partial claw hand over a period of time. So they will come with partial claw hand, on probing on the history. They will tell you that this patient had an history of fall, and then it was treated somewhere else some 10 years back, 15 years back, and now he develops this ulnar palsy. What is the meaning of tardy? Tardy means it is slow ulnar palsy. right? So that is the tardy ulnar palsy in case of lateral condylar fracture humerus. So this is supracondylar and this is your lateral condyle. Lateral condyle, remember the important points. It results in non-union, 3-point relationship is disrupted. It on chronic complication is your tardy ulnar palsy, which results in claw hand. On the other hand, supracondylar fracture humerus results in malunion, which is called as cubitus varus, where there will be limitation of flexion, but the patient can do hyperextension, and the treatment here is a French me. And the image given here is your gun stock deformity, that is your cubitus varus, right? And then what is this? What is this? Yeah, it is a unilateral CTEP. Right, you can see only one foot which is into CTEP, right? So what is the deformity of CTEP? Cavus, adduction, varus, equinus. So the correction of the order is also the same. So first you have to correct the cavus, then you correct the adduction, then varus, then equinus, which is given and told us by the Ponseti. So there is a Ponseti technique which we use. Correction is in the same order, that is cavus, adduction, varus, and equinus. So where do you see this cavus? This is very, very important. Cavus is seen in the midfoot. Adduction is seen in the forefoot. Varus is seen in the hind foot. Equinus is seen in the ankle. Right? So that is how you remember. So this is cavus, and the treatment immediately as soon as possible, even on the day 1 you can start, right? And what is the treatment? Serial cast. Serial casing is the serial casting or serial casing you do. How do you correct? The order of correction is 𝐒𝐿, and this is given by Ponseti technique, right? And if it is not corrected, what is the treatment? What do you do? Yes, you do go posterior medial soft tissue release, called PMSTR. That is soft tissue release. What this is the first option is serial casing. Second is PMSTR. Third one is deformity correction, like you correct the varus deformity or you correct the adduction deformity. So the third option is deformity correction, and last and final option, the fourth option is triple. So serial casing you give in case maybe probably for less than 3 years you can still do this, and you have to always go for soft tissue release when the patient is age of 3 years, and this can be done up to 8 years. Then this is 11 years, right? Triple fusion, triple arthrodesis. Right? So now serial casing, when it is corrected by serial casing, then you go for your Dennis Brown splint, and then you go for your CTEV shoes. That is about your CTEV shoes. Yeah. The triple arthrodesis is between 𝐒𝐿𝐾𝐄𝐝, talonavicular, and talus and the calcaneum. Talocalcaneal, talonavicular, and calcaneonavicular. Right? So that is about the triple fusion. So all the 3 joints. So between the callus, that is talus and the calcaneum, calcaneum. Then between the talus and the navicular, talonavicular and the cuboid, calcaneum and cuboid, right? So just remember it this way. So calcaneum will be like this. Over it will be talus. So you fuse the talus, then in front you fused with the navicular, and then you fuse with the cuboid. Talonavicular and calcaneocuboid. Understood? So this is the talocalcaneum, talonavicular, and calcaneocuboid, right? So this is about the CTEV, where you go for serial casting. You do in the order of CAVE, that is CAVE. Then once it is corrected, you go for DB splint for 24 hours, and then you go relax it for 12 hours, right? And then finally you go for CTEV shoes, where there is a no heel rise and straight inner border, right? CTEV shoes, what is the difference? No heel raise and straight inner border, right? So these are the criteria for CTEV shoes. So straight border is because again it should not go into varus, right? So varus and adduction. So that is how you have to do. Yeah, talonavicular, talocalcaneum, and calcaneocuboid. Correct. Now you have written it correctly. So this is the CTEV shoes, DB splint and the CTEV shoes. CTEV shoes, no heel rise and straight inner border. That is about your CTEV, right? And then what is this? Very, very important. Yes, this is your GCT, giant cell tumor, also called as your osteoclastoma. What is the most important thing? Seen in the epiphysis, right? Yes, soap bubble appearance on the X-ray. On biopsy, what you see? You see the giant cells among the small cells which are mononuclear, which is very, very important, right? You see the giant cells here on biopsy. And how do you treat it? You treat it by extended curettage, where you use adjuvants like phenol, bone cement, right? So phenol, bone cement, these all you use, or liquid nitrogen. So this is about the extended curettage, right? Extended curettage. So extended curettage is nothing but you scrape out all the tumor particles. So this is somewhat which is aggressive, right? So it is aggressive. So you scrape out everything, and after scraping out, what you do is you put phenol, or you put the bone cement, or you put the liquid nitrogen, so that all the tumor elements die, right? And you have to always check for biopsy. On biopsy, you see there is a giant cells with mononuclear cells, usually seen in the epiphyseal region. The eggshell crackling sound is present, right? And this is extended curettage, which is the option or treatment for your GC. Very, very important. Usually seen around the knee. Most common area is knee. Most common area is, right? And what is this? This we have already discussed. What is this? This is dynamic or static? Dynamic or static? Yes, very good. This is a dynamic cock-up splint. So this dynamic cock-up splint, why? Because you can see there are springs, right? So there is a movement which you can do like this. So this is a dynamic cock-up splint. What is this? Final one, what is this? Yeah, that is used for your radial nerve injury. We have discussed that already, in detail, the cock-up splint, the dynamic and the static. What is this image? What is this? I'm waiting for the answer. Oh, pencil thin cortex. It is used seen in. So this is a mallet finger. If you can see, this is the fracture. And this mallet finger is nothing but a damage to the extensor tendon on sudden flexion, right? On sudden flexion, if there is a damage to the extensor tendon, this is called as a mallet finger. Patient will be unable to extend, right? So this is a mallet finger. Mallet finger, patient is unable to extend, right? So what is jersey finger then? What is a jersey finger? Very good, Pratyusha. What is a jersey finger? Similarly, damage to the flexor tendon, that is due to sudden extension, right? And now patient will unable to flex. So remember, mallet is like this. It will be like this. So patient will be unable to extend it like this. We will put his finger in this way. So this is a mallet finger. So damage to the is avulsion fracture again. Avulsion fracture of the mallet fracture, right? And what is jersey finger? Jersey finger is damage to the flexion because they will hold the jerseys like this. You know, jerseys, they will hold it, and because of the sudden extension, they will be damaged to the flexor tendons. Damage to the flexor tendons, and they will be unable to flex it. So that is about the various tables and the images in the magic of 10. So I have one more this thing. So I have come up with the, so one more question which you have to remember is this one, the Salter Harris. So physis, important question, physis you have to remember. So the Salter Harris is very, very important. Recently they have asked in every exam. So because of what is the physis is nothing but the growth plate, right? The area from where the growth occurs. It has 3 zones. Roughly you remember, one is the reserve zone, then you have the proliferating zone, then you have the hypertrophy zone, right? So this hypertrophic zone is very, very important, which is the weakest area. So whenever there is a fracture in the physis, it occurs in this weakest area called the zone of hypertrophy. And based upon that, this Salter and Harris has divided the classification. So how do you remember? You have to just remember the name Salter. And there are 5. 1, 2, 3, 4, and 5. There are 5 types of physeal injury occurring in the children, and they go in the name of Salter, where S is for straight. So this straight fracture which is occurring through the physis is through this zone of hypertrophy. And when that is A, so here the damage occurs above the physis. So 2 is above the physis, A for above. That is, what is above the physis? It is the metaphysis. It is the metaphysis, and there is a fragment which is called as, what is the fragment name? So what is the example of the metaphysis? Metaphysis injury example is your supracondylar fracture only, right? The straight example is your SCFE, slipped capital femoral epiphysis is there, no? So that condition, there is a fracture in the physis, that is the weakest area is the zone of hypertrophy. Next is above. This is the metaphysis which is getting involved. Okay, you tell me the that fragment. What is this fragment? The small fragment called. Then L is lower, that is below the physis. So the epiphysis will come into play. This epiphysis will come into play in case of lower, and through is full. That is complete from the from the metaphysis and the epi. All the 3 are involved is through. And then E and R. E and R is your crush injury. But rank has come with one more 6, that is your perichondrial ring. That is outside the physis. Outside the physis, there is one layer which is attached. This is called the perichondrial ring. If that area is involved, then that is 6. So these are the Salter Harris classification. This is called third step Poland class fragment. Third step Poland fragment. Holland fragment. So this fragment is called the third Holland fragment. An example of this trait is skiffy. Example of second type 2 is supracondylar fracture, and type 3 is lateral condyle fracture, lateral condyle, and through is ankle. Usually the ankle fractures are through and crush is the open injuries. Any crushed injury or open injury, you can go for type 5, right? So this is very, very important. You have to remember. That is your Salter-Harris classification. And one more thing I want to remember is this question. What is a care of neck of femur? This has been asked again in the exam. If the patient neck of the femur is fractured, you have to understand that neck of fracture, two types: IC fracture, IT fracture. Both are neck fractures, IC and IT. If it is an IC fracture, go for hemiarthroplasty, because already we know that this is an area for non-union. So you're going to replace the head, which is called as hemiarthroplasty. If it is an IT fracture, you have to fix it. Head is quite happy, nothing to do with the head. So you go for PFN, that is proximal femoral nailing. So whenever there is a neck of the femur fracture, you have to first depend upon the age, less than 60 years or more than 60 years, right? So usually if the patient is less than 60 years, you have to go for hemi. More than 60 years, you go for THR. And if the patient is even less than 40 years, you go for CC screws. CC screw in inverted triangle fashion, right? Right. So if there is an acetabulum involved also, you directly go for THR. If the patient is having less than 60 years but the acetabulum is damaged, you go for THR. But usually remember, IC fracture is hemiarthroplasty, IT intertrochanteric. So now this is a example of hemiarthroplasty. Hemi matlab, hemi is half. Arthroplasty means plasty is change. Arthro means joint. So you're changing the joint. So you're removing half of the joint. The half of the joint is your femoral head. The half of the joint is your femoral head. So you're removing the femoral head and you're changing with this. What is this called? This is called the prosthesis. This is called the prosthesis. And this prosthesis is a bipolar prosthesis. If you see two holes here and if you see two holes, this is your Austin Moore's, right? So whenever you're replacing something, this is called as prosthesis. When you're retaining the part inside it, this is called as implant. This is an implant which is called as proximal femoral nail. How do I identify the proximal femoral nail from just femoral nailing? You see one screw inside the head. If this screw inside the head, this is called as PFN. No screw inside the head. It is just intramedullary interlocking femoral nail. Right? Very good, Pratyusha. So this is about your implant. So you have to understand what is a hemiarthroplasty. You have to understand what is the prosthesis. There are two types of prosthesis: Austin Moore's, Thompson's, and bipolar. Austin Moore's have two holes in it. Thompson is like this. A collar will be placed. This is the head and this is the collar. So whenever you see collar, this is the Thompson prosthesis. And nothing is there. It is a bipolar prosthesis. And now this is an IT fracture in the area of the neck between the trochanters. Whenever there is an IT fracture, you go for a PFN, proximal femoral nail. That's it, right? So let's wind up answering these 10 questions in a quick mode, right? So what is the criteria for septic arthritis? These are one-liners. It is the Koch's criteria. So what is Koch's criteria? Non-weight bearing, temperature more, ESR more, WBC more. ESR more than 40 mm, WBC more than 12,000. Right? That is the Koch's criteria. Ivory sequestrum is seen in syphilis, right? And what is the RA factor? Is a type of dash antibody, anti-IgM antibody, right? Pages. That is ivory vertebra. Pratisha, you're right, you're right. That is ivory vertebra. That is why you have to read the question properly. Ivory sequestrum is seen in syphilis. Ivory vertebra is seen in Paget's disease, right? What is the drug of choice in acute gouty attack? It is NSAIDs, colchicine, steroids. First is always NSAIDs, then colchicine. Then if it is not reducing, then you go for steroid. The marker that is highly prevalent in ankylosing spondylitis, HLA P27. Kellengren-Lawrence staging is used for grading of osteoarthritis. Rickets is a disease of demineralization. The classical X-ray finding in osteomalacia is Looser's zone, right? You will see multiple Looser's zone in case of your osteomalacia. So rickets and scurvy, very, very important. There will be defect in vitamin D, hence the calcium is not transported and it will result in loss of calcium and phosphorus together, which is called as the demineralization of the bone, right? And what is the familial hypophosphatic rickets is dash inheritance. Usually it is X-linked dominant. So what is this hypophosphatemic rickets? That means there is decrease in phosphorus. So whenever there is a decrease in phosphorus, also there is a demineralization. This is called X-linked dominant. If it is X-linked recessive, what is that is called as? A specific name is given for X-linked recessive hypophosphatemic rickets. What is that name? It is called as dash disease. Faster. Decrease phosphorus. Okay, that is all fine. I'm asking if there is a, so usually this familial hypophosphatemic rickets, usually this hypophosphatemic rickets is X-linked dominant, but in few cases it could be X-linked recessive also. If it is X-linked recessive, what is that disease name called as? Called as? Called as dent disease, right? Dent disease. Good. Okay, now next, what is Sunderland second degree corresponds to Sedan's classification. So in case of, the nerve injuries, there are two types, Sunderland's and Sedan's classification. So Sedan's, what the first one, which are divided into neuropraxia, axonotemesis, and neurotemesis. Sunderland's given as 4 grades, 1, 2, 3, 4, and 5. This is Sunderland. Sedan's is neuropraxia, axonotemesis, neurotemesis. Now, Sunderland second degree. This Sunderland second degree is corresponding to which of Sedan's? I want the answer. So how to differentiate between scurvy and rickets? I'll tell you one easy thing. What to remember is, so if I take rickets X-ray, if I take scurvy X-ray. No, not peripheral nerve injuries. I am asking you, yeah, Sunderland second degree corresponds to axonotemesis, right? The answer is axonotemesis. right? So how this first is always first. Sunderland 1 is neuropraxia, but Sunderland 2, 3, 4 is axonotemesis, 5 is neurotemesis. That you have to remember, because Sedan has given only neuropraxia, axonotemesis, and neurotemesis. That means this is just a concussion. There is no damage. This is damage, and this is cut. Directly the nerve is cut. But Sunderland has given further more modification. So he has told this is concussion. One is one, but two is just damage to the axons, but all the layers are intact. Three is endoneurium is damaged. Here what happened? Endo plus epineurium is damaged. Sorry, endo plus perineurium is damaged. Here endoneurium, perineurium, and epineurium is damaged. So that is corresponding to neurotemesis. Tinel sign positive in axon and neuro. So Tinel sign is positive in case of axonotemesis. Yes, axon, not neuro. Neurotemesis, there is no Tinel sign because the nerve is completely cut. In axonotemesis, only the nerve regenerates because there are some layers which are still intact. So whenever the nerve is regenerating, the Tinel signs becomes positive, right? So now coming to the X-rays of scurvy and rickets, which I wanted to tell you. Rickets is a disease of demineralization. That means there is no calcium and phosphorus. So if you remember, the calcium is responsible for your white color in the X-ray, right? You're seeing the X-ray, the bone as white in color because of the presence of your calcium. Now what happened? The calcium is completely absent. So what you find is the lucency, right? So whenever you see the X-ray lucency and you see all these features of cupping, so because of the loss of the whiteness, you see the cupping, which is very clear. Then you see there is a flaying, that means ends are like this, and then you see there's a fraying, that means all those abnormal irregularities. So lucency, whenever you see, it is rickets. On the other hand, what is scurvy? Scurvy is collagen deficiency. So there is lot of calcium, phosphorus, but there is no collagen. Hence, your scurvy will appear white in color. So all densities, so the pulk and spur, the zone of calcification, and whatever you see white color, Wimberger ring sign. So Wimberger ring sign is nothing but the epiphysis is lucent, but you see the calcification of the calcium, that is the ring sign. So you see white more. So you see calcifications because of the presence of calcium. That is how you differentiate between rickets and scurvy. So rickets is a disease where you see lucency because calcium is not present in the body. Here scurvy, there is a lot of calcium. That is why you see this ring sign. The calcification is prominent on the X-ray. On the other hand, the collagen is not there. So these structures are lighter in color, right? And you see subperiosteal hemorrhages there in case of your scurvy. Scurvy is vitamin C deficiency. Vitamin D deficiency is your rickets, and both together is called your Barton's disease, right? Yeah, to some extent. Yeah, in case of your Tinel sign, you can see, yeah, Durkan's test and Tinel sign are all examples for your carpal tunnel syndrome. So carpal tunnel syndrome, Durkan sign is direct compression of the median nerve. This is the most sensitive test and most specific test for your carpal tunnel syndrome. So most specific test for carpal tunnel is your Durkan's test for your carpal tunnel. So I think who has asked me this? Yeah, KK, is that clear? Scurvy and rickets? Okay. Now let's end the class. Thank you so much. It was so interactive. I have to especially thanks all the people, Pratyusha, Naveen, Raj, Sakshi, KK, Ravinder Singh, all those people, you have really answered really well. Thank you so much for making class easy for me. See you all. Okay, tomorrow again we have this SF booster on the app, not on the YouTube. On the app, we have having this one shot. So you can, yeah, tell your friends who want to revise ortho. That is one shot. So we are trying to, complete the syllabus, the entire syllabus in like 2.5, 3 hours with more of, exam oriented for NEET PG aspirants. So for that, you have to register to the app and then you have to be present for tomorrow's class, which is live only on the app, not on the YouTube. Thank you so much. Good night. All the very best. And do let me know your results after writing your exams. Would be really happy to learn from you that what you are answered with, what, what made you to attempt that question easily and all. So, hope you will return back with your experiences from the exam. Thank you. Good night. Bye.